Okay, I think I will start now. We've got a good number of people with us right now. So welcome everybody this morning to the virtual point prevalence survey training. We're delighted to have you with us and thank you for registering and attending. My name is Will Townsend and I work for the Tropical Health and Education Trust and we go by THET. And we're an NGO that supports health system strengthening and human resources for health through health partnerships between UK institutions and individuals and colleagues and institutions in low middle income countries. This training is hosted by THET and the Commonwealth Pharmacists Association. My colleague Diane, who works for them, will give a brief about them shortly. And the training is delivered in collaboration with the Global Point Prevalence Survey team, who are represented by Anne Desporton and Ines Powells, and one of the authors of the World Health Organization Point Prevalence Survey Methodology, Peter Zarb. Next slide, please. And this training is brought to you through the CWPAMS program, which stands for Commonwealth Partnerships for Antimicrobial Stewardship. And this was established to strengthen the capacity of institutions and individuals in relation to antimicrobial stewardship across Ghana, Tanzania, Uganda, and Zambia. But the scope has since expanded to include sessions such as today's. And again, my colleague will go into a bit more detail about the CWPAMS program. And yes, this is part of the Fleming Fund, which is a £265 million UK aid investment that supports 24 countries across Africa and Asia to generate, share, and use data to improve antimicrobial use and encourage investment in AMR. So thank you to, yes, the Fleming Fund for their support in delivering this today. Next slide, please. So just some digital housekeeping. Please remain muted unless invited to speak, and please also keep your camera off just to help with bandwidth. Please use the chat function to comment and ask questions and communicate with others. The session is being transcribed live through otter.ai. So in the top left of your screen, you should see a little button you can press and that will show live transcription. And I'll also add that session is going to be recorded and they'll be available online afterwards. We will send a follow-up email to everybody who registered. So you'll receive details of that after. The next slide, please. Yes, and if you haven't already, please do complete the pre-training questionnaire as soon as possible, particularly before the main training presentations start. So please do that as soon as possible, and there should be a link to that sent in the chat function. Otherwise, please just do type into the browser. Now, yes, I'm going to stop there, and I'm going to hand over to my colleague, Diane. Thank you, everybody.
Thank you, Will. Hopefully you can hear me and see me okay. Just apologies, 1 second, I've just lost my screen for a minute. So welcome everyone. So my name is Diana Schroder. I'm the Global Antimicrobial Resistance Lead for the Commonwealth Pharmacists Association. CPA, we exist to empower pharmacists to improve health and well-being throughout the Commonwealth. Our mission is to improve access to and quality of medicines and reduce health inequalities, and also to manage the safe and effective use of medicines to improve health outcomes and to improve the health literacy and promote healthier lifestyles across the Commonwealth. So we're very much focused across all the Commonwealth countries and support more than 1 million pharmacists across the Commonwealth. Next slide, please. In terms of CWPAMS, as Will highlighted earlier, our aim was to leverage the expertise, particularly in pharmacy and of UK institution volunteers and technical experts, to strengthen the capacity of national health workforce and institutions in 4 Commonwealth countries, 4 African Commonwealth countries. So initially Uganda, Tanzania, Zambia, and Ghana. And we had 12 partnerships across there between the UK and 5 within Ghana, 1 institution in Tanzania, 1 hospital in Tanzania, 5 hospitals in Uganda, and 5 partnerships in Uganda, and also 1 partnership in Zambia. Some of those partnerships had multiple hospitals working with them, and also multiple organizations were also part of the partnerships. And there was a strong focus on antimicrobial stewardship, including surveillance, which is where the point prevalence comes in. And we'll talk a little bit more about that today, or a lot about that today. Antimicrobial pharmacy expertise and capacity, and also infection prevention and control. As you know, to tackle antimicrobial resistance, we need to both use infection prevention and control and antimicrobial stewardship. Next slide, please. We developed a range of tools and interventions, all focused around, all using behavior change strategies. Examples were the healthcare workers survey that some partnerships could use. We also developed a checklist tool to provide a baseline for antimicrobial stewardship activities within each of the hospitals that we partnered with. And we developed this before the WHO had published its own assessment tool, which is now available for use in hospitals, in healthcare facilities. We also developed an antimicrobial prescribing app, which has been important in increasing access to antimicrobial prescribing guidelines in the countries. Next slide, please. Again, we also just one moment, please. I'm just going to flag to colleagues from TEF to have a look at the waiting room and in terms of admissions. Health partnerships and just being cautious. Health partnerships that we had successfully trained more than 1,500 healthcare workers in Ghana, Uganda, Zambia, and Tanzania on antimicrobial prescribing, consumption surveillance, and infection prevention and control. And 253 of these volunteers were pharmacists, both within the UK and in the 4 countries. And also we amassed a total of 1,982 days in terms of training and workforce. And you can see there, the slide, on the right side where you can see colleagues in both Zambia and UK is an example of bidirectional learning that we had, where when COVID hit and we became a resource limited setting in the UK, in the fact that we ran out of alcohol hand rub, the learning that colleagues had when they went to Zambia became really useful in their hospital, because they were able to then locally produce their alcohol hand rub using the WHO formula. Next slide, please. As I mentioned, we did an antimicrobial stewardship baseline assessment for CWPAMs, so in those hospitals, and there were a range of questions that we asked, and we used a consensus method building on a previous international publication. And then we went back out to colleagues in the 4 countries to ask them to reassess whether or not these questions were the most appropriate ones to use. And what you can see there was that there were very few hospitals, in fact, only 2 hospitals that somewhat had antimicrobial stewardship protocols in place. And infection prevention, whereas infection prevention and control, there were more hospitals that had those in place. After CWPAM's intervention and the process through that, colleagues have also now reassessed their stewardship activities within those hospitals, and we can already see a shift in the activities that have occurred within those hospitals. Next slide, please. And then in terms of antimicrobial use in Global PPS, we use the Global PPS methodology at the start of CWPAMs for a number of reasons. At that time, the WHO PPS had not yet been published or available, and also because we were focused on individual hospitals developing their interventions. So the aim for CWPAMs was to assess the data, have the data available, and to use that data for immediate action. So for us, that was really key. So that was, we used Global PPS. And today, though, you'll hear about both the WHO PPS and the Global PPS. And there are some slight differences and nuances on when you can or can't use them. Next slide, please. I mentioned that we developed an antimicrobial prescribing app, and again we have been able to share the findings from that, and including a pilot implementation in one of the hospitals in Ghana. And the feedback from the healthcare workers highlighted that more than half of from healthcare workers and patients, the patients had a positive attitude to the use of the app by healthcare professionals. We had wondered if patients would have a bias to their healthcare professionals using a mobile phone whilst talking to them. And so we developed posters that could be placed around the healthcare professionals to highlight to the patient that actually the fact that the healthcare professional is looking at their mobile phone is to make sure that they're prescribing them the most appropriate medicine. And then also what was interesting for was that the pharmacists and nurses felt empowered by using the app. Next slide, please. We also developed a toolkit afterwards. It was a collation of all the resources and strategies and examples that I come across through the 12 partnerships, and a wealth of information. So we now have an online repository of resources, and that is available through CPA's website, and the link is available as well. But if you just Google CWPAMS toolkit, it will come up very easily. Next slide, please. We had an interim evaluation of the CWPAMS program from last time, because it started, it went through an 18-month period, but because of COVID, there was a slight pause and a no-cost extension. But at the point where we were able to evaluate, the program had an aggregate score of 78, which was very good. And it was the evaluation criteria used was relevance, effectiveness, impact, efficiency, and sustainability. Efficiency was our lowest score, which was still good, was 63. And we're working at the moment to make sure that we improve on those efficiency. Next slide, please. So since the CWPAMS completed, in terms of the partnerships, the formal part of the partnerships completed, some partnerships have been having an opportunity to do a little bit more extra work, and we're in an extension period. So there are, I think, about 3 or possibly 6 partnerships who have carried on and are doing some additional pieces of work with their as a partnership. But at the same time, the program team have also been doing quite a bit of work around rapid systematic evidence synthesis. So we're doing a scoping review, and many of you on the call have probably been part of that. And it gave us an opportunity to scope in 4 new countries: Nigeria, Kenya, Malawi, and Sierra Leone. And so we are doing a new scoping through those 4 countries, and we're updating the previous scoping that we did in the initial 4 CWPAMS countries. And we've done that through a process of literature review, and then having focus group discussions with national focal points, with the AMR coordinating committee, and different professional groups as well. We have been scoping also for a leadership program. So one of the key aspects of CWPAMS was that we had a leadership program for the fellows. So we had some global health fellows we developed through pharmacy, and we've now been scoping to find out how we can use learning from that to support colleagues in the 8 countries to develop pharmacists further in their leadership skills. We have also developed an antimicrobial stewardship board game, which provides an opportunity and an option for training in a different way. And there is evidence to show that when you use gaming as part of training, it is useful and supportive. The CPA has developed a CPD educational platform, which will include a range of training opportunity, but we have started off with antimicrobial resistance and stewardship. And whilst it's primarily for pharmacists, I believe we have opportunities for others to be able to access the training as well. And finally, the app, we have been working to further implement the app, and also to work out to increase the usability of the app. And finally, the point prevalence training, which is where we are today. And one final one, which is not on the screen, is the GESI training. So the importance of gender and inclusion within our project. So that's another training that will occur in July, and further details will be sent to you. Next slide, please. So a reminder, we'll ask you to go to Mentimeter in a moment, but a reminder, and really important, that you complete the pre-training survey, and the link was sent into the chat earlier, and I will just post it again now. So really important, Will has just posted that, the pre-training survey, because we'll have the pre-training survey and then we'll have a post-training survey. And after that, we'll be able to issue certificates for those who attend. Because for us, the certificate will not be a simple case of people turned up to the event. It will be turned up and had an opportunity to reflect on their learning. We're not testing you. This is not about testing you. It's also to ensure the effectiveness of our training. So please do take time to complete that. We need to have a close, we will stop the pre-training from 9:30, I guess, once we start the training part, because then that no longer is pre-training, because you would have had some information from us by then. So please do complete that form now. It will take you less than 8 minutes to complete it, and you can do that as we talk through the next few sessions. So I'm going to pause for about 3 minutes to give people opportunity to complete that. And then we'll go to the Mentimeter. So Kieran, actually, if I could ask that we go back one slide. So if everyone can please just focus on the pre-training survey for the next 3 minutes, and then we'll go to the Mentimeter next. I'm just going to post that back into the group now. So the link is in the chat. So far, we can see that 95 colleagues have completed the form, and there are 176 on the call, which is great. So we'll just give a few more minutes for colleagues to be able to do that. And Peter's just reminded us that we have colleagues from all different time zones on the call. So that'll be an interesting one. What time is it where you are? If it's similar to the British time zone, that's totally fine. So if you're anywhere between 9 a.m. and 10 a.m., that's fine. But if you are at a different time zone, middle of the night or evening or very early morning, we would love to hear about it. And thank you for joining us. Okay. Australia, thank you. Great to have colleagues from Australia, India, Kenya, Uganda, Melbourne, Australia again, excellent. Philippines, Cambodia, wow. Welcome, Syria, excellent. Bhutan, amazing. This is great to hear where different colleagues. Bangladesh. Yes, if you've done the survey before, you do not need to do it again. You do not need to do it again. Welcome, Nigeria. Colleagues from Nigeria. Pakistan. Wow, Zambia. Excellent. Thank you, colleagues. Really great to have you here. If you've done the survey beforehand, not a problem. Latvia. Excellent. We have colleagues from all over the world. Jordan. Excellent. Welcome, welcome. Okay, we now have 181 colleagues on the call. That's amazing as well. Okay, so Kieran, let's go to the next slide, please. So for the next one, we want you to go to Mentimeter. And I think if it's easier, I think it'll be good to put the link in the chat as well, please. So if you go to mentee.com, and we'll put the link into the chat now with the code. So the direct link is that. You should be able to click on that link and you should be able to answer that. Kieran, if you can share your the Mentee slides, Mentee page, please. Thank you. The purpose of these slides is really just very quickly for us to know who we have in the room in terms of hospitals or coordinating committee. It just helps us as we start to discuss to be able to adapt the our talk based on who we have. So we can see that we have majority of colleagues on the call are from hospital and also other settings. Okay, Kira, I think we can go to the next question. So remind, I'm just posting the link into the chat. If you click on that, it should take you directly. Then you should be able to put your details of where you work and profession. So at the moment we have several pharmacists and doctors and microbiologists, nurses. Great to have we've got a lab technician as well. Great to have a multidisciplinary team on the call today. Next question, please, Kieran. Okay, and next one. So in terms of how involved people are in antimicrobial stewardship, we have, so the average is about 3.6. So we have those who have no involvement at all the way up to those who are heavily involved. So hopefully, as we go through the session, those who are heavily involved, feel free to share your tips and your personal reflections. And those who have no involvement at all, we have assumed no prior knowledge. So we'll go through the process for you and hopefully you'll be able to gain from that. And that's why it's really important for us to have that understanding of who's in the room, who's with us today from all over the world. Okay, so I'll just put the link again. If anyone wants to vote on the Mentimeter, that's the link to vote on there, please. And the next question, Kira, is that the last one? Okay, so have you been involved in PPS before? We have about half and half who have and haven't been involved. Okay, that's great. And where are people from? This is a really good one. Although it's been able to spy that a little bit earlier. Kieran, I may need your help for this because I can't see it as clearly. But Kieran, wait, if you can maybe tell us where the different people are. Okay, that's helpful zooming in. The number with 12, what country is that, please? You may be able to see it better, or maybe hover over them and then I can call them out. So 12 is
India. Sorry, Diane.
It's 15. Yeah, go on, or Will or Kieran. Yeah.
India.
So 12 is India, and 16 is that No,
Nigeria.
Nigeria. Okay.
Mm-hmm.
And 8.
Philippines.
Excellent. 5.
Northern Europe, Diane.
Northern Europe. Excellent. Thank you very much. So we have got colleagues from across multiple continents with us today. That's excellent. Thank you very much. Okay. Next slide, please. Oh, I think that's the end. Okay, excellent. So thank you very much for that. You can continue to vote. It's really helpful for us to have this information. So please just take a few seconds to do that. We are about to go into our next session, which is the training session. So we will start off with the Global PPS team, Anne and Ines, who will present the Global PPS to us. And then we'll go to the WHO PPS, which will be presented by Peter. And then we'll have a session where we just highlight the similarities and the differences between the two tools, the Global PPS and the WHO PPS. So Anne, before you start, if I could just get you to pause for a moment. We still have about 2 minutes, so we're ahead by 2 minutes. So I would just like to give people an opportunity one more time, if they haven't, to complete the pre-training survey just very quickly. So I'm just going to put the link again into the chat, or if Will has done it already, just an opportunity for colleagues to do that. Again, if you did that yesterday, please, you do not need to do it again. This is just if you haven't done it already. And we can see that we're now 199 of us on the call, which is absolutely brilliant. So we'll just give a few more minutes for colleagues to complete the pre-training survey, especially for those who have just joined us. Okay, for those who have just joined, we just put a link into the chat for the pre-training questionnaire for colleagues to complete. Okay, Anne, I make it 9:30. Please do feel free to get started with your presentation. You cannot complete the pre-training questionnaire afterwards. You'll be able to complete the post-training questionnaire afterwards, but not the pre-training questionnaire.
Good morning, good day to everybody. Can I start, Diana?
Yes, you can. Please don't forget to make it a slideshow.
I wish everybody a warm welcome. Let me do it slideshow. Yes. I have seen several people known to us, to the Global PPS experts in their field. So really a warm welcome to everybody to this session and to the training. I will go and walk you through the Global Point Prevalence Survey, more specifically on the method being used. So this is myself. I'm coordinating the Global PPS since 2014, actually, where we piloted it and then conducted it for the very first time. So, but let me go straight away to the next slide. I will walk you through a little introduction, the birth and the aims of the Global PPS, how you can start the Global PPS in your hospital, go through the method, explaining the method through an example straight away, and then very short how you can export your data, get feedback results, and a little discussion also very briefly the way forward, because a lot of it will be told to you afterwards. But first of all, I think many of you will be known with the report, the review on antimicrobial resistance the report led by the economist Jim O'Neill, which was published in 2016, where 10 steps were actually identified, 10 action points to reduce antimicrobial resistance and to improve antimicrobial prescribing. I will definitely not go to all of them and just pick out some to come afterwards to the surveillance. We all know that a massive global public awareness, for example, is very important to improve the awareness so that patients and farmers do not ask antibiotics when it is not needed, and also physicians and veterinarians do not prescribe them. Very known to you will be the World Antibiotic Awareness Day, now organized by the WHO. Also improve hygiene and prevent the spread of infection. It was very essential in the 19th century, but even up to now, it's very much true. If you can prevent infectious disease, you will not need to prescribe antimicrobials, and you will be able to prevent the antimicrobial resistance. But then let me come straight away to surveillance. Surveillance is also one of the cornerstone of infectious disease management. Yet actually it has until recently very often been ignored and very often under-resourced in the fight against antimicrobial resistance. And there comes in the point prevalence survey. If you can't measure what is going on in your hospital or what is going on at the national level, you will not be able to improve it. So that's a very essential point to work on, surveillance. You have completed some questions, and this will give you a slide giving some answers on what is actually a point prevalence survey, a prevalence, the method prevalence as compared to incidence. The incidence is the number of new cases in a given population. You follow up a cohort in a certain period of time and you count the number of new cases, for example, new cases of MRSA infection. Prevalence, you look at a specific number of cases in a given population at a specific time. You can define a point prevalence survey at a specific day, for example, like the Global PPS and the WHO PPS, but also a period prevalence. Then it's more useful, for example, when you deal with low numbers. That is, for example, done within GARPEC. I'm not going into detail. Anyway, so let me go to the next one. How did the Global PPS started at the University of Antwerp, where the Global PPS team is based in Belgium? We have somehow quite some experience regarding antimicrobial consumption and resistance. So in 2006 and between 2006 and 2009, the European, there was the European surveillance of antimicrobial consumption. Not only outpatient use was measured, but also inpatient use using the point prevalence survey. So it was led also by the University of Antwerp. Thereafter, there was another project which was run between 2011 and 2012. It was called the Pps, where we developed a protocol specifically to survey antimicrobial resistance and prescribing in European children. But anyway, we even went in 2012 worldwide. All of this is published. I put down there some publications. Peter Zarp was among them from the very beginning, who is now will present you the WHO PPS. He was one of them with us in the very beginning. This was based on a European funding. So then in June 2013, there was the 4th edition of the World Health Economic Forum on Healthcare-Associated Infections and Antimicrobial Resistance, which was held in Annecy in France. And there it was decided that we should continue with that method because it's very useful for hospitals. So bioMérieux decided to fund this method, a point prevalence survey, to measure antimicrobial consumption and resistance in the hospital. So a protocol was set up, it was piloted in 2014, and we call it the Global PPS. The first worldwide Global PPS was conducted in 2015. It was published as well. You see the publication below, and then also repeated in 2017. And since 2018, we opened 3 surveys a year. And we continue to do that. And even most probably in 2022, we will even open more surveys because we see that repeated point prevalence services towards antimicrobial stewardship is very useful. So what are the aims of the Global PPS? To offer a valid, feasible, and sustainable surveillance tool to monitor rates of antimicrobial prescribing and resistance, not only in hospitalized adults, but also children and neonates worldwide. Want to determine the variation in drug, dose, and indications of antimicrobial prescribing, and also very important, using those results, identify targets to improve not only antimicrobial prescribing in your hospital, but also to allow you to prevent healthcare-associated infections, because we also developed a new module. I will come back to that later on. It will help you to design stewardship interventions. That's a very important aim of the Global PPS as well, to promote prudent antimicrobial use. And then, because it's really a simple method, you will be able to repeat the PPS, and then if you have set up certain stewardship actions, you can assess the effectiveness of the interventions you have set up in your hospital through repeated PPS. And at the very end, what it's all about, we want to raise awareness on appropriate antimicrobial prescribing, which is very important. Some features. The Global PPS is freely available. It's there for all hospitals worldwide. The participation is on a voluntary basis, so there is no remuneration foreseen for the hospital participating. You use a uniform standardized methodology, which you have to follow strictly. And we also offer a free, simple web-based application for data entry, where there's a lot of quality assurance embedded in that system, a data validation process, and also importantly, a feedback reporting, so you can evaluate what is going on in your hospital. Important to say is that there is also a possibility to centralize data entry. I have seen there are a lot of participants here in this session joining from the Philippines. So when you centralize the data entry, you can have access to all the data and come up with results for the country national point of view. Some confidentiality principles. The very important also, patient level data entry online is completely anonymous. I will explain that to you later on using the data collection forms. The data are also strictly confidential and safely stored on a secured server at the University of Antwerp. So we use a web-based application, and those data will at the very end will be stored on a server in Antwerp. So you know that. But of course, the hospital builds up you will be able to build up your own database, and you remain the owner of your own database. It's very nice that there is also a possibility of data sharing with a third party, but that is only done after explicit written approval of the hospital. So we can be link you up with other hospitals in the country, or even of other countries. So for example, within the aim to have a joint publication. The names of the hospitals are never revealed in any report or scientific publication without written approval of the hospital. It's very important. You deal with sometimes really sensitive data, not only antimicrobial use data, but also resistance data. So we are very careful to that. And I think it's also important for the sustainability of the project that the confidentiality here also is guaranteed. There is a data privacy excerpt and also publication policy available on our website. So you decide to join us, the network of the Global Pps. How can you start? We believe that it is very important to create a team. You can't do that on your own. So it's very nice to create a multidisciplinary team, only this one in your hospital, that you start to think about what about antimicrobial consumption in our hospital is already a very nice exercise. Sit together on the table and form a team. Of course, there should be a lead. Also for us, it's good to identify a local Global PPS administrator, a focal person for your hospital. On our website, there are a lot of materials which you can see, and I post one of these down on the slide here. Below on the left side, we offer, for example, posters where you can seek support for your efforts you're going to do to improve antimicrobial prescribing in your hospital. Those posters you can post anywhere in the wards or anywhere where you want, and they are easy to translate and customizable. Ethical approval depends really on the country and also the setting. Countries where it is not needed because it is considered as a retrospective audit. For example, in the UK, it's like that. It is considered as survey evaluation and quality improvement. But there are a lot of other countries where ethical approval is needed by the hospital, like in Canada, in Belgium, and so many other countries. You will need ethical approval. We have a data privacy excerpt available for that purpose. In 2021, there are 3 survey periods available, and every hospital is free to participate in just 1, 2, or all 3 survey periods a year, even afterwards in 2021. But it is important to say here that whenever you decide to participate, preferably following the protocol, you survey the hospital within 1 month, within a certain survey period of 4 months. Yeah. The Global PPS data collection, a little bit more about the method. It will give you a snapshot of what is going on regarding antimicrobial prescribing and resistance at a particular time in your hospital. There is no sampling of patients at the ward or hospital level. I want to stress on that because that's a difference with the WHO PPS. So whenever you decide to survey your hospital or a set of wards in your hospital, there is no sampling. So Whenever you participate for the very first time, we do ask you, if possible, to survey the whole hospital, but afterwards, it's just to get a feeling of what is going on in the hospital. But afterwards, it's perfectly possible to participate with a set of wards in your hospital. And then we ask you to include all wards of a certain ward type. For example, all intensive care units, all pediatric medical wards. And the reason is because we use that type of ward, department type, in our feedback report. So you have, when you repeated the PPS, you have comparable rates over time. When preferable you conduct a PPS on weekday, not during weekends and not during holidays. Surgical departments are a little bit particular in the sense that they are not to be surveyed after a weekend or holiday. Why? Because only for surgical departments, when you will have surgical patients who receive surgical prophylaxis, only for those patients, you go back retrospectively in time to capture the duration of surgical prophylaxis. You go back 24 hours. So, for example, the protocol says also that if most interventions are planned for on Tuesday, we will ask you to survey this ward on a Wednesday. So you can go back and look also and capture whether the duration of the surgical prophylaxis was one shot, multiple doses one day, or more than one day. All wards need to be surveyed just once, not necessarily, but preferably within 1 month, as I mentioned before. We have a lot of materials on our website. We are very transparent in that. We have, for the moment, 9 translated protocols, even in Vietnamese recently. So I take the opportunity even now to thank all those people who on a voluntary basis help us to translate those protocols and those data collection templates. Sometimes I'm so warmly happy that we get this help because everything is done on a voluntary basis. It's fantastic, actually, because you help not only yourself, but also other hospitals and countries speaking the same language. We kept the protocol quite simple, but of course, there are always questions coming up. So we have also a frequent asked question list. And when you have a question, I'm just saying about sepsis, you can, it's a Word document, you click in sepsis, you type it in the search option, and then you fall on the questions regarding sepsis. So you can look up the frequent asked questions there. There is the IT manual, and also tutorial videos are available to help you with the data entry. We have the list of surveyed antimicrobials and also a PowerPoint slides on the methodology is all available on our website, which is posted below slides. So let me go straight away to the methods, which I will explain to you through an example. But first of all, for the Global PPS data collection, there are 3 paper forms. So we ask participants to collect the data on paper forms, but let me tell you straight away, it is also possible to enter the data straight away online onto the Global PPS application. But then you will need to have all data straight ready in front of you, otherwise you will encounter issues. But let me continue with this one. There are 3 data collection paper forms. The first is the ward form, and the ward form is there to collect the denominator data. So when you go to your ward, you just print this, for this ward form just once, and you collect the number of patients present on the ward before 8 a.m., the number of beds available on the ward at 8 a.m. And then we have also an optional healthcare associated infection module, which is available since the end of 2019. Then you can also, if you choose to participate to that module, we ask you to count the number of patients with an invasive device, because we are specifically interested in the use of invasive devices. This is the denominator. Then we have the numerator. We have a patient basic form and a patient healthcare associated infection form, which is optional. And then you print those forms for each patient on that day of the PPS, which is on at least one antimicrobial. So, an example. I hope you're still with me. So imagine, very simple, you wish to start the Global PPS data collection in Ward B of Hospital ABC, and it's on Thursday, the 1st of July in 2021. Ward B is a gynecological ward with 35 beds. You reach the ward at 10 a.m. And at 10 a.m., there is a total of 30 patients in the ward. And all those 30 patients were admitted to the ward before 8 a.m. 25 are medical patients admitted for gynecological obstetric reasons, but somehow there are also 5 overflow patients, if I can say, from the abdominal and thoracic surgery ward, which also occupy a bed in that ward B. How would you complete now the ward form? This is how the ward form looks like. So here, let me walk you through, maybe not quite so fast. You put the date of the survey. You remember 1st of July, the person completing. This is important to write it down specifically for bigger hospitals. Is very useful because you will not be able to do all the work on yourself. So if you delegate some work, so you know who has surveyed that ward, the hospital name, and the ward name, which is unique for your hospital, a unique ward name. Then you define the ward type. There are predefined ward types. There are the adult wards and the pediatric neonatal wards. And the adult wards, we have general or mixed adult medical wards, but we also specify specific types. Imagine you have a real, for example, a real ward with only neurologic patients, you can take neurology. But here we know it is gynecology and obstetrics, so you take gynecology obstetrics. Yeah, we know from the example also that actually there were 5 patients from other specialty, so we can put yes. And the activity, we have 3 activities defined. There are medical patients, surgery patients, or intensive care. So here, if you remember, there were 25 medical patients for obstetrics gynecology reasons and 5 surgery patients. And we had 35 beds. And here you have to see how you complete this one. But as they were overflown from another ward, we now decided to put here 5 and here 30 medicine, because it is normally gynecology obstetric ward. If you decide to participate also to the healthcare associated infection module, you will need to complete also denominators for this extra module. And here we ask you to complete the number of admitted inpatients. So you count the patients who are on the day of the PPS having at least 1 invasive device. Urinary catheter, here you have at least 1 peripheral vascular catheter, central vascular catheter, but also drains. And we also added in May 2020, we added even non-invasive positive and negative mechanical ventilation, because you will also be able here to survey specifically COVID-19 patients. So we adapted our protocol at that time as well. Then that's our the denominator. What about the patient form? First of all, the inclusion criteria. So you, for the numerator, you collect detailed antimicrobial consumption data only for those patients admitted receiving an active antimicrobial prescription at 8 a.m. on the day of the survey. So in practice, this means, let's say for your hospital, you have a hospital with 200 admitted inpatients a day. Let's say you have an occupancy rate of 100%. And if you know you have an estimated average antimicrobial prevalence of 50%, then it means for the Global PPS that you will collect detailed data only for 100 inpatients for the entire hospital and not 200. You see? So that makes it also more simple and maybe feasible to do. Exclusion criteria, day hospitalizations and outpatients are excluded, are not surveyed. Patients admitted on the ward after 8 a.m. on the day of the survey, and those patients are not counted in the numerator and of course also not in the denominator. They're just not visible in that survey. There are two patient forms. The first patient form is what we call the basic patient form, where you collect detailed data only for those patients on at least one antimicrobial. We collect patient data, age, gender, weight, antimicrobial prescription data, of course. We are interested to know which agent, dose, route of administration, diagnosis, indication, and then also very typical for the Global PPS, a set of quality indicators, antimicrobial quality indicators, is a reason why your antibiotic is prescribed by your clinician in this hospital written down in the notes, yes or no? Is a stop review date of this antimicrobial prescription written in the notes, and also guideline compliance. We take as quality indicators. And then we collect also microbiology data where you can take targeted versus empiric use. The patient healthcare associated infection form, if you decide to participate as well to this module, you will collect data on the presence of invasive devices for all patients on antimicrobials. Comorbidities, it's also mandatory to complete, but there within that form, I will show you it afterwards, there are also a lot of variables which are even optional to complete. For example, all variables relating to a date is optional because we know sometimes it's really difficult to collect those data. Which kind of antimicrobials do you include? They are prescribed at 8 a.m. on the day of the survey. So it's written in the notes that those are prescribed on that day. You include active and ongoing antimicrobials. It means that, for example, you have antifungals, let's say, but they are prescribed 3 times a week, but by accident, not on the day of the PPS, you still include them and you add a weight. There is a in the frequent asked question list, you can look up how to do that. So which one do you include? Of course, the antibacterials for systemic use, antimycotics and antifungals for systemic use, drugs to treat tuberculosis, intestinal anti-infectives, the nitronidazole derivatives, antivirals for systemic use, and the antimalarials. So it's a whole set of antimicrobials. Those one in green, and that's a difference with the WHO PPS, are not captured in the WHO PPS. They do it in a different way, but Peter Sarp will talk to you about it later on. Antimicrobials for topical use are excluded. An example. I hope you're still with me. Let's say we have the date of the PPS, again, the 1st of July in 2021. We have a 28-year-old lady admitted to the Ward B on Saturday, 26th in June 2021 for a complicated breech delivery, and she has already 2 children. So on that day, on the 26th of June, she had an urgent sexio delivery, and they inserted a peripheral vascular catheter. Somehow 3 days later, on Tuesday, the 29th of June, she developed a fever. And what is written in the doctor's notes on the 29th of that day, that the abdominal wound is red, feels warm, the wound dressing is very dirty, she has fever, 38.5, she's tachycard, patient is very tired. And somehow they decided to make an incision in the wound and drain the wound, insert even a drain and send a wound culture to the lab. So it seems to be she's pretty sick. Doctor decided to start ceftriaxone 2 grams once daily for a surgical site infection. And then the day after, the doctor visits her again and there is no deterioration and he decided just continue treatment. Another note, the hospital does not have a guideline for treatment of surgical wound infections. If you read that one, how would you complete now the patient form, the basic patient form? It is split up in several sections. The first on top is the patient characteristics. Very simple. Which ward, the activity, she's underwent a surgery, so is surgery. Here the patient identifier, if you remember that the data collection is anonymous, but here on this paper form, you have the opportunity to write down any patient identifier for your hospital, but you will not be able to enter that online on the Global PPS application. Instead, when you have saved all the patient characteristics, you will receive an automated generated survey number. And we ask you to write down this survey number here in this empty field. It's important. Why? Because this survey number allows you to make the link with the data which you will have in Excel in your database for your hospital with the information written on the paper form with that patient identifier. Yeah. So the patient age, the weight, we don't know. It's an optional variable, so you can leave it empty, and the sex. The treatment based on biomarker data, we say no, we have no information, so you do not need to complete also all the other information. And yes, there was a culture sent to the lab to document the infection. You can tick even wound surgery biopsy. As you remember, they did an incision and they sent the culture to the lab. Here, it's important to know that wound swabs are not counted, but just an ordinary swab is not counted. But if you really take a biopsy or a sample, then you can score it. Then the antimicrobial information, very important, ceftriaxone, here the name, when it started, we know it, it was the 29th of June. If you don't know, you can leave it empty. And then of course, the single unit dose, 2 grams, once a day, parenteral, yeah. Then you can complete a diagnosis. Is it surgical site infection and skin and soft tissue infection? And the type of indication is a healthcare associated infection 1. Let me go to the next slide to explain the diagnosis, because we work with codes. So here you have the diagnostic codes. It follows the anatomical site of infection. So, and here I marked in red the skin and soft tissue infection. Importantly for you to see is that we divided also by anatomical site of infection. You can choose between whether the antimicrobial or the antibiotic is given for therapeutic use to treat the infection or for prophylactic use, medical or surgical prophylaxis. And those ones are highlighted in light gray. As you see, I point your attention also to COVID-19. We added this code as well, specifically for you to survey COVID-19 patients. It's one we have to deal with now in those time of days. And then here you have the type of indication. You remember for our example, it concerned a person with a healthcare associated infection. the healthcare-associated infection. He got a wound infection 3 days after her surgery. So it's 48 hours after admission to the hospital. And you can score it as a healthcare-associated infection and you can give it 1. You see there are several codes to attribute for a healthcare-associated infection. I will not go through all of them, but if it is not clear to you what kind of healthcare-associated infection it could be, no problem. There is also a very common code for it, and that is HAI, for other hospital-acquired infection of mixed or undefined origin. Yeah. Of course, here you have also the community-acquired infection, surgical prophylaxis, medical prophylaxis, or other. Let me go up again. So, and then you complete further with the quality indicators. You have the reason in notes. I explained it already. And yes, we saw that the reason was written in notes. Guideline compliance at the very end, if you remember, it was clearly said there is no guideline available. Let me explain you the codes. You can score it as yes, you can score it as no, and A actually says that it's not available. And it's important to score that very well because we analyze that in our feedback reports. And D means not indicated. And it means that if you don't know the diagnosis, you will definitely not know also which guideline to use. So it's not indicated, then you can also score it as such. Stop review date documented, no. Let me go back. Here they said, doctor's note, the 30th of 06, he said no deterioration, continue treatment, but it's not clear when or how he will review the treatment. So you can document it as no. The treatment is empiric, it's not target, so it's not based on a microbiological result. In case, imagine you will have a microbiological result available on the data of the PPS, you can maximum score 3 microorganisms, and for each microorganism, you score 1 resistance type. And the resistance types are here. So here you have the different resistance types which can be scored. They are the most common ones encountered worldwide, and we even added the azolus as it becomes also more and more important. We see more and more resistance against azolus, against antifungals rather. This is the list of microorganisms by resistance type. It's the data collection.
I'm so sorry, Anne. Your volume is going in and out. If you could please just keep the mic, maybe hold the mic. Sorry, apologies.
Oh, maybe I have to stop my...
No, it's fine. You just need to hold your mic a bit closer so it's stable.
Okay.
Thank you.
Thank you, Gianna, telling me. I hope it's better now. Sorry. So then let me come back to the same patient form example, but I just highlighted some words in red. You remember it was an urgent cesarean delivery, 26th of June. There was a peripheral vascular catheter inserted. And in the doctor's note, it was written that it was a drain inserted. How would you complete it if you decide to also participate to the optional health-associated infection module? It looks like this one is an extra form, and those one highlighted in red are mandatory to complete. Here, surgical procedure during current admission in the hospital.
Sorry, Anne, I'm really
Yes.
sorry. Anne, I think you may need to hold the mic so it's stable. Yeah, apologies.
Okay, sorry. Thank you. Then the next one inserted, we are interested to have the inserted information about the inserted invasive devices present at ATM on the day of the PPS. And here we know that, we know that she had a peripheral vascular catheter, and we even know the date. If you don't know, you can leave it empty. And there was a drain inserted, you can score it as yes, and we even also know the date, you can put it there. MACAP score, severity score, is also mandatory to complete. It's not available. And the underlying morbidity is also mandatory to score. We don't know about it. We say here, no. It's a young lady, but you could as well have ticked a no. Let me go to the next one, so I'm not taking too much time. So whenever you have collected the data on the patient the data collection forms, you can sit behind your computer and start entering the data onto the web-based Global PPS tool. This tool is accessible via our website, theglobalpps.com. When you scroll down a little bit, you will see this data entry, and when you click on Read More, you will follow it. You can also go directly through this link. I will explain it only shortly, but when you enter the data online, you really need to follow a certain procedure. You really need to proceed step by step because the program is designed as such. First of all, you need to do some preparatory work, and this is only to be done once. You create your hospital and your departments. Important to say also that you can, as a local administrator, add extra hospital users, so that you have people in your hospital helping you with data entry. So you can do that as well through that tool. And you can even add as many as hospitals possible. So you have access to all the data for all the hospitals that you that you survey. So you select, of course, the appropriate survey, and then you enter first the denominators one by one. And only then when you have entered the denominators, because we do not want to lack those one, otherwise we will not be able to calculate rates, you enter the patient data using the patient forms. When you have done all of this, there is the validation of the data. During the data entry, there are a lot of embedded internal checks allow you to enter the data as valid as possible. For example, it is not possible to enter, for example, a link between a certain antimicrobial and the dose. So there are some internal checks there. And then there is the validation procedure after validation, after finalization of the data entry. I will be just very short here because we have materials available to help you with this. We have our IT manual, which is available on our website for the public, but we also have now instruction videos available, and those ones are available on the data entry environment when you register to the tool and when you logged into the tool. After you have entered your data, you can have results, of course, but there are two ways of providing you the results. First, there is the extraction of raw data. It's provided to you in an Excel file. Actually, you can do that at any time. So you can look during data entry, how much have I entered, and also verify your data if everything is correctly entered online. And afterwards, of course, you can download the full set of data for your own purpose to analyze your data in more detail. There are also the feedback reports. Whenever you have validated your data, you will be able to download 3 types of feedback reports. The 1-point feedback report, where you have rates of your hospital compared to the country, the region where you belong to, and European results. So it's the benchmark data. Short, because Ines will talk you through and give some examples to you later on. There is a longitudinal feedback. When you participate multiple times, you will be able to see the trends of the use, antimicrobial use in your hospital. And also merged feedback, which is very particularly interesting for participants who participate with multiple hospitals. And so you can merge anything you like, for example, for a particular region, or for example, only the tertiary care hospitals. So you can do anything as you like. So, but more information will be followed, and Ines will talk you through those ones. So to conclude, there is a common methodology and a uniformity of data collection to collect valid, importantly, and comparable antimicrobial consumption data. We keep very hard to this one, and we work hard to obtain those valid and comparable antimicrobial and resistance data. There is a benchmarking at country and regional level. The protocol is simple and the tool is free. You can use it as you like for data entry and validation. There is a quality assurance through the validate and also through the data when you enter the data online, but also afterwards. There is a free central support anytime when you encounter issues is always possible. You can contact my colleague Ines Pauwels or myself for any question regarding data collection or other. And there is a data sharing open agreement with all partners, and I refer here to you to the publication policy which is available, and you can ask us this publication policy. So any hospital can participate. And we really warmly welcome you to join us in 2021. And we put the contacts here from the Global PPS team, and the PAMS contact is Diana. The next steps. So this is the method. This is a start. Measure what is going on in your hospital and obtaining the results. But the next step, I think, is a more difficult part. How are you going to improve now, using those results, antimicrobial prescribing in your hospital? So this one will come after the break and will be elaborated in much more detail with Diana and Ines. So that brings me to the last slide for questions and answer. I would be happy to answer them.
Thank you very much, Anne. That was really, that was great. I was learning new things as well, so really grateful. Thank you. So there have been several questions asked in the chat, and Peter has been kind enough to answer some of them.
Oh, perfect.
What I'm going to ask now is that if anyone's asked a question that they feel hasn't been answered, if you can raise your hand. We are not allowing everyone to be able to unmute themselves, so we will have to unmute you just really to make sure that we keep the platform safe. So if anyone's got any questions that has not been answered, or if there's any question that you can see that hasn't been answered, then please do let us know. I'm just going to read out a question here, Anne, for you. It says, it's from Can. It says, if two patients or more share the same bed in the ward, how do we calculate the number of total bed? Because in the protocol, the number of beds has to be greater than the inpatient number.
It's very common. That is not a problem at all. So you just count here the number of patients. If you have, let's say, 30 beds, but you have two patients in one bed, you count the number of beds as equal as the number of patients. So if you have on that ward for those 30 beds, 40 patients, you put in beds 40. So that's no issue at all. Yeah.
Thank you.
Yeah.
See if there are any other questions. So again, if you've asked a question that you want more replies to, please put them in here. So there's another one from JB George, which says, hello, Anne, I'm JB George from India. We have participated in 2014 Global PPS. My query is that, can we use the same ethics committee approval for conducting the same in 2021? I suspect you will need to check within your hospital.
Exactly, Diana. Yeah, that is something we can't really intervene. We can give you all what you need. There is a data privacy excerpt, but there are also hospitals who even ask more detailed data. We can provide it to you. And if it is necessary for you to go through the ethical approval again, I have never ever heard that one hospital was not able to get the approval. So I don't think it's an issue. Yeah,
I think you will need to check with your ethics committee, because it depends on what you put into your ethics form. Did you put it as an ongoing process, or did you put it as a one-off? So certainly in the UK, hospitals are expected to carry out audits, and that's an ongoing. So there's a blanket bit of ethics that different departments would have filled out, and it may last for a period of time, so 5 years, or you may have to renew it. So it's not so much ethics for us, but there's an internal hospital process for carrying out audits. So I think you'll need to check. Another question here is from Joan, says, my center has 2019 data. We could not upload for technical issues. What can we do? I suspect the answer is to contact Ines and Anne, our Global PPS team. I don't know if Ines wants to put your email address into the chat so that it's easy for Joan to contact you. Usman says, can we only include antibiotics specifically and leave other classes of drugs such as antivirals and antimalarials? And that's a question for you. So can they?
In theory, it's possible. It's not advisable, but we do have a slide in our feedback report who reports the number of patients on antibiotics, antibacterials of systemic use only, and then all those who receive other antimicrobials like antifungals. So, but if you have it available on the patient chart or in the medical file, you can as well collect it, because we see there is an example that Ines will show to you later on. If you collect also information about people on drugs to treat tuberculosis of antimalarials, it will definitely influence also your the prescribing of antibiotics. So it could be useful information for you, I believe. So in theory, it's possible, but I don't think it's advisable. Yeah,
I guess it depends on what the hospital's focus is. If you have a strong focus, and I know in some countries, antimalarials is it's the biggest part of the antimicrobials that they collate or that they have as well. So I think, if it with stewardship is what the focus is for your hospital. So if you know your hospital and think antivirals and antimalarials is an important part that you want to survey and collate information on, and that functionality exists, I would encourage you to use it as well. Obviously, knowing that the Global PPS wasn't set up for that. So there's another question. Use of biome. So Aditi, please do post your exact question into the chat again, because I can't see it further up. So a question from Path02. Use of biomarkers should be considered at the time of starting antibiotics or on the day of the survey. So when should they? Is it?
The protocol says you note down the most relevant value which is available to you, not only on the day of the survey, but it can be the day before as well. The timing there is less important. Yeah. First of all, we ask you if there is biomarker data, if the clinician has used biomarker data, which we are most interested in PCT and PCR. CRP rather, yes or no. And then we ask the detailed data, which is available for the most relevant for the patients in question. Yeah.
Okay. There's a question, is TLC acceptable as a biomarker?
TOC. We have also added recently white blood cell counts, and we have the section also other. Peter Zarp is very much more familiar, I believe, than me regarding biomarker data, but I have to tell you, when you put it as other, we hardly analyze it because it can be anything. People put there maybe anything, and it's not that often used also. But for specifically the one you mentioned, there is a category other.
Yeah. And again, as with stewardship, depends on what you want to focus on in your hospital, what the challenges are in your hospital. So if you can collect data, and even if it's not fully analyzed through the Global PPS, you can still pull out your own data and analyze it through the Excel spreadsheet if needed.
If I can maybe add something, the Global PPS is there, first of all, to support the hospital, the local hospital. So what is important to you And if you follow the protocol and there is a code for it, you can do it. For yourself, you will know that you have done this, this, and this. But of course, for benchmarking and the reporting through us, the Global PPS team, yeah, this information will not be captured. But it can be useful for you in the hospital. So, yeah.
So we will need to stop this session soon so we can keep the time, but I'm just going to read out a few more questions. So hello there. So essentially the participation of a hospital in this data collection platform allows for healthcare professionals from these facilities to obtain advice and guidance on antimicrobial therapy. So that's a question from Greg Buds. Sort of. I mean, Anne, you may want to answer this, but I think it primarily, so they're asking if they can get advice and guidance on antimicrobial therapy. Primarily, it's a surveillance tool, and it's a tool for you to get data to help inform your stewardship interventions. Ines and Anne are Ines and Anne are working through a training program on how you can use the surveillance tool, Global PPS, to inform your stewardship interventions. Part of the training we'll provide to you today is how do you develop antimicrobial stewardship interventions as well. And with CWPAMS, we're going to take that further. So I don't think, I mean, Anne, correct me if I'm wrong, that you provide advice and guidance on which antimicrobials to use for which indication. I don't believe
No. Actually, that is also a very big difference with the relatively difference with the ECDC PPS. Here, you just go on your ward, you revise your charts and what is written by the clinician in the medical files or in the patient files, and you don't question whether the antimicrobial prescribed for a certain indication was wrong or right. So you write down the diagnosis, what the clinician intends to treat, without, if I understand the whole logic behind it of the question. So that's an important one.
Yeah, I think it doesn't provide you information for your hospital. I think you need to develop your own guidelines, and I think that it will help you to know where there's inappropriate prescribing in a way. So if they're indicating and you have a guideline and it's not following, but that's a next step to that. You'd have to analyze the data slightly differently for that. Okay, so there's a question. Please elaborate on the forms used to collect the data in hospitals. All hospitals in country need to adopt the forms. I think it will become a bit clearer when we go to the WHO session as well. So I recommend that we wait until you've heard the WHO session as well. It's basically if a hospital wants to use the Global PPS, then they need to use the forms so that they can input the data and get the automated feedback. I'm going to go a question from Adi T, which says, if surgeon prescribed antimicrobials for post-operative case for fever, raised TLC, what code should we write? So this is not, so basically, it sounds like treatment to me, but I'll let you answer. So he says, the clinicians erroneously classify such a prescription as prophylactic and prescribe antibiotics like piperacillin. It becomes difficult to assign a code. There are usually no other markers of infection, just pop-up fever and raised TLC. We have the same challenge. So this is where they've prescribed an antibiotic after the surgery. And the surgeon has said it's prophylaxis. What do they code it as?
It's in the example that we give for the lady of 28 years old, you remember it was very clearly that she had a wound infection and it was a healthcare associated infection, but we do see in our data truly that clinicians prescribe surgical prophylaxis and keep on providing this for days and days, that it is not prophylaxis anymore and that you wonder. So,
So I think with that one, it's almost a case of when you're doing the analysis that you'll be able to pick it up if they have. But and just correct me if I'm wrong. When they're completing the form, they need to write it what the prescriber intended. So if the prescriber said it's prophylaxis, on the form they need to state it's prophylaxis. Is that correct?
Yes, instead, yes.
Even if
So you don't have to invent yourself, huh? Or if it is questionable, if you don't know, you can go, it happens, huh? You can go to the clinician or you can ask more information from the clinician, what is it for?
Yeah.
You can also do that, but not necessarily.
But if
Yeah.
they've prescribed the antibiotic after the surgery, even if they've said it's prophylaxis, it isn't prophylaxis, though, is it? It's how do they code that? So
Preferably, yeah, if it is really to treat an infection, it's far more better to pick the code for the treatment of an infection in the diagnostic list. You remember I pointed out, and also in the indication list, community-acquired healthcare associated. But indeed, from experience, I can tell you, we see a lot of medical prophylaxis that we wonder, what is it prescribed for? But the most important thing here that we can conclude is there is a lot of prescribing and it's not known, so we can work on that. We can improve there.
So I think one of the key things is that it talks about on the form, when you're going to look at the prophylaxis, you need to look from a day before the surgery. That's right, 24 hours before.
Yes.
If it has been prescribed after the surgery, you can code it, but somehow you need to, it's not prophylaxis anymore if they've prescribed it after the surgery, even if they call it prophylaxis, right? But because that's not what the WHO surgical sites infection guidelines is. So I think maybe we need to consider that, and in essence, how maybe think about that going forward. Okay,
Yes.
so it says where an antibiotic is being used for more than one indication, what do they do? Do they include all the indications?
Yeah, it is true. For every antimicrobial, you can write down only one indication and one diagnostic code and one indication code. And then you need to pick up the most important one. Indeed, it can be that a patient is having a pneumonia and developed also a sepsis. Then it's up to you to decide. Yeah, that is true. Unless what we see as well, if the patient gets several antimicrobials or several antibiotics to treat the pneumonia and the sepsis, we see that one is prescribed for pneumonia and the other, I'm just saying, carbapenem for the sepsis.
Peter's just replied that for GPPS it's main indication only, but for WHPS you can include more than one. But again, we'll explain some more differences. There's one final question I'm going to take, and then we're going to move on. And then someone asked, can you communicate if you get stuck at any point? Yes, via email to the GPPS team. They are very responsive.
Yes.
So it says here, do you finish all the patient forms on the day of the PPS? If hospital staff get too busy and they can't finish the patient forms for that ward, can they finalize it on another day?
Yeah, perfectly.
Let me rephrase that question. You're on a ward and you get busy, you can't finish that ward. Can you come back another day to finish the ward?
Yeah, perfectly possible. It's a retrospective audit. The only thing is that you need to be careful. You have this ward and you look what is prescribed at 8 a.m. on the morning, or you pick it an hour on that day, and then you revise all your medical files. Several hospitals are doing that. Yeah, it's possible.
I don't understand that, Anne. So if I come in 8 o'clock on Wednesday, there are 50 patients. I only get 20 patients. By the time I come back on Thursday, there are only 30 patients left. What do I do then?
Okay, then it's not clear from the medical files. Then it's an issue.
Oh, I see. So you'd have to basically go and find the medical files of the patients that were on the ward that day. So I think that's an important point, is that you need to find the files of all those patients. And if you can't access those files of the patients from the previous day,
then you have an issue.
Start again.
Then you need to do that on that day. Yeah.
Right, that's clear. Okay, we're going to move on now to the WHO presentation. Thank you very much, Anne, and for that great presentation. Over to you, Peter.
Good morning, good afternoon, good evening, wherever you may be. Can you hear me? Yeah. Okay. So,
Peter, sorry, Peter, we can hear you, but reminder that we are a lot closer so we can.
yeah. So
hear
in
the
fact,
volume.
I switched off my
Yeah,
camera,
that's
so I stay closer to the screen.
no problem. Thank you.
So before starting my presentation, I just inputted 2 comments with respect to the last questions we had. Indeed, if you have a very big word, what the WHO protocol recommends, and it's probably could be also done with the GPPS, is that you can split the word in 2. So bed 1 to bed 25 would be, I don't know, gynecology ward 1, 26 to 27, 26 to 50 gynecology ward 2, for example. So that you're sure that bed 1 to 25 is done on day 1 and finished, and bed 26 to 50 is done on day 2 and it started and finished the following day. But that's something, I mean, just an idea which has been happening with the WHO PPS when we did it in Tanzania. So back to my presentation. I'm Peter Zarb from Malta. I'm trying to. Okay, so what I'll be mentioning is first there's a short icebreaker, some generic epidemiology PPS information, some of which is a bit of an application which has already been discussed by the previous presentation. So I'll be quite rapid in going through those slides. Then a lot of detail about the WHO PPS methodology. I will not go through the actual protocol and all the forms because that would take too much. Some perils and pitfalls from experience. And finally, I'll wrap up with the key take-home messages referred to as conclusions. So now I'll pass on to Kieran for 2 Mentee questions. So if you can now please go to Mentimeter, Mentee.com. Oops. Kieran?
Thanks, Peter. Yeah, so if we can, Peter, if you could share that screen again, just so everyone has the code, that would be great. Thanks. And then I can share my screen to show the results.
Kieran, I think if you share your screen with the results, it shows the code anyway, so you can just do that now.
Yeah, sure, no problem.
So Peter, don't worry about sharing.
All right.
Great, yeah. So if everyone can go to Mentee.com and on my screen, you should be able to see the code here. The code is 8431-1692, and there will be 2 questions to answer. So if anyone has any issues, please just put it in the chat.
I've just posted the link so you can directly click on it and access the code. Peter, we've got colleagues saying the volume is still a bit low, so sorry.
All right, so I'll get even closer to the...
Yeah. And apparently they loved your Eurovision entry in Malta.
Pardon?
Someone, Sarah's just said they loved your Eurovision entry.
Actually,
Actually, let's not talk a bit more because that's the next question, isn't it?
no, it's not the next question. But actually, I'm one of the few Maltese nationals who, let's say, not follow it, not to say anything more damning. So I think with respect to this question, we can stop here.
Next question.
Next question, please. So they've already answered, all right. Okay, I think I can take Kieran, I'm taking over again, if it's all right.
Sure, Peter, I'll just stop sharing now.
Okay. So indeed, Malta is a member of both of the European Union and the British Commonwealth. Some notes about me: I'm a pharmacist, not so young anymore. I've been working on antibiotics since 2000, and also specifically dedicated to intensive care since 2008. Obviously, with this pandemic, I had to give up a bit of the intensive care duties. As Anne said, I was involved with ESAC and now at ECDC ESACnet. I'm the secretary for the National Antimicrobial Antibiotic Committee, which is the AMR board in Malta, and I've also had experience as a facilitator on antimicrobial consumption and antimicrobial use with the WHO. With respect to consumption, it's the longitudinal total consumption, whether it's hospital or community or overall, whereas antimicrobial use is the term we give to the PPS. So data can be valid, reliable, or none of the above. So taking here the first green circle, the data is both valid and reliable, which means that the data collector applies the definitions in a consistent and correct manner. In the second example, which is brown, the data collector is applying definitions incorrectly in the same way every time. So it is reliable, it is the same, but it's not valid. And then the last one, it's the worst case scenario where everything is all over the place and there's neither definitions nor correctness throughout. Incidence and prevalence has been described in the previous presentation, but if we take these horizontal lines as cases, they have different durations and they start and finish at different points in time. And the incidence is 6 cases in this period of time, whereas the prevalence across this arrow, I don't know whether, yeah, across this arrow is 3 cases because the first and the third cases have finished and the 6th case has not started yet. So this becomes important when we look at point prevalence surveys. A note on prevalence surveys with respect to antibiotics, it's as opposed to consumption, it provides information on dosing and indication, and from that you can derive whether the right drugs are used for the right indications, and that's a target for quality improvement. So if you see that many people are using, I don't know, piperacin tazobactam for community-acquired pneumonia, which should not be the case, maybe comoxiclav would be sufficient. You should instill local guidelines targeting that area. So that's one point. So evaluating appropriateness. The negatives, it's quite resource demanding. Surveyors must be clinically trained because very often you will not find the name of the indication written. You will not have pneumonia. You might find consolidation, lower lobe. And you have to translate that, be able to translate that as a pneumonia. Another issue is disruption to clinical work. And not always the question about anonymization and safety of data storage must be ensured. So if you do not have a copy of the methodology, it can be accessed from the WHO website. Here is the link here. Maybe later on I can share it directly with you. So going to an overview of the methodology. So who is it for and who is it not for? So usually, well, as a start, if you have the protocol, you can run the survey, but you, as an individual hospital, but you will not get support from the WHO country office or WHO regional office or WHO headquarters, but you can run it. However, as a general rule, it's done top down. So the country decides to participate through the WHO country office, and the individual hospitals are selected or invited centrally by the national coordinator, and I'll come to that in a few slides. It is specifically developed for low and middle income countries, as opposed to the ECDC PPS or the Global Pps, which are originated in Europe. I mean, this has specific fields like the reason why a dose was missed, and I'll come to that in a few slides down the line. To get WHO support, and when I say WHO support, I'm not referring to financial. This is not a financially supported initiative, but technical support. It's not given to individual hospitals or groups of hospitals, but only at the WHO country level. The data structure is more or less similar to the global PPS, but obviously there is the national aspect of it. And there is ward data, hospital data, ward data, patient data, and the patient data, then it's split further into the indication data, the antibiotic data, which are interlinked, and for those patients in whom there is a microbiology specimen, there's also that aspect involved. Some considerations for the national planning. So, as I said, it's top-down, so the authorities, usually the Ministry for Health, would choose the national coordinator or national coordinator team, which would still have a leader. This team will take the necessary background information about the country, the number of hospitals, the bed size of the hospitals, and the number of hospitals and the number of beds per hospital will be important when it comes to selecting hospitals. There are two options, random or convenient sampling. When we go through random sampling, you list the hospitals by bed size, for example, and if you have 100 hospitals and you need to take at least 30, you choose every third hospital. So like that, the sample is random and systematic, and it's unlikely to have bias. Convenient sample, on the other hand, is based on whether the hospital is willing to participate or not. And that's obviously, that can be biased and cannot be taken if you use a convenient sampling. You cannot take that as a picture of the total country situation. And obviously an invitation can be optional or mandatory, depending on the health system. But obviously, if it is optional, it can still remain a valid systematic sampling, because if the one that rejects, the next one will be selected, and it's still considered as a representing the country. Also, the national coordinating team must ensure training of local hospital coordinators and the central investigator team, which might act as trainers if there are local personnel involved in the collection of data at the hospital level. At hospital level, as mentioned by the GBPS presentation, the busy dynamic wards may be difficult to get access to, especially if there's the ward rounds going on. So one must be careful to visit when it's maybe less busy. Find space to work without disrupting the ongoing duties of the ward. And importantly, if there isn't sufficient information on the patient notes or the admission book or any form of documentation, you can discuss with the ward staff or with the prescribing clinicians about the indications of treatment. However, it is important to highlight that these are not interventions, and if you see something which might even seem stupid, it's, as a ward assessor, you are not there to give advice and to recommend changes. So no interventions whatsoever. Good communication is important, so the wards have to add, first and foremost, at national level, the hospitals have to be advised in advance of the dates of the survey. Similarly, at ward level, at hospital level, the hospital coordinator needs to communicate with the wards, informing them of what the PPS is and on which day their respective ward will be done. Timeline, I think this applies also to GBPS. A hospital has to be finished within a maximum of 3 consecutive weeks. And this refers to the specific hospital, not at national level, at hospital level, 3 consecutive weeks. So you cannot start doing 1 day a week for 2 months. It's 3 days, 3 weeks maximum. And the duration of the survey will depend on the size of the hospital and the size of the team, as well as the experience of the team, because the more experience you get, the more likely you'll go fast through the patient notes. So these are things to be thought of, and ideally there should be a pilot phase before carrying out the actual survey so that all investigators are familiar with the system. With respect to hospitals, there are different types, and the definition of primary, secondary, tertiary, and specialized hospitals is not fully standardized. So you might, but as a general rule, a primary hospital is quite local. Secondary is somewhat more of a regional. Tertiary hospitals are usually the reference centers, and in many countries you would have one national tertiary hospital and some satellite tertiary hospitals in other big cities. Specialized hospitals refer to hospitals which deal only with one specific condition. For example, infectious disease hospitals, or even TB or malaria hospitals. So those are specialized hospitals. In many countries, there are groups. In the UK, I'm familiar with the term trust, so NHS trust, but in other countries, they might be referred to as chain merger group. With respect to hospital ownership, it's also important to classify the type of hospital. And some countries will only have, for example, public hospitals registered and participating. That obviously cannot be taken as a systematic sampling, and it will be biased, reflecting only the public sector. Something very common in low and middle income countries is the next one is private, non-profit hospitals, which are not common in high income countries, but it's something to keep an eye on. Inclusion and exclusion criteria are identical to the GPPS, so I will not spend too much time on the slide. With respect to ward types, they are similar but not identical to the GPPS. So we have pediatric, adult, and neonatal. With respect to pediatric, there's medical ward, surgical ward, high-risk wards, and intensive care. Similarly to the adult, with respect to neonatal, there's neonatal medical wards and intensive care. Neonatal medical wards usually are the nurseries, if these are not part of the labor wards. So that's something to keep an eye on. Mixed departments, you can have, if there's more than 80% of patients from the specific one group, the ward is classified as that group. But you can have mixed adult wards, mixed adult and pediatric, or mixed pediatric wards. An important note is that some specialties like orthopedic, otolaryngology, ophthalmic are usually classified as surgical departments. So there's no subspecialties for this type of ward. And the definition of high-risk wards includes wards that are more likely to have higher antibiotic consumption. And these include hematology wards, oncology, burns, transplant, and infectious disease wards. Please note that intensive care units, they are sort of very high risk. So they are not part of this category. They are a category of their own. With respect to patient level data, the WHO point prevalence survey uses patient data on all patients. This is similar to the ECDC PPS and different from the Global PPS. And this is an important aspect if we're looking at antimicrobial use and risk factor. For example, if a patient has a urinary catheter, it is usually more likely that the patient will have an antibiotic or not. If the patient is intubated, if the patient has a vascular catheter, so on and so forth. So that's why this kind of information is important. Also, there is collection of data on whether the patient has TB, malaria, or HIV, but at this point in time, it might change in the future. There is no collection of data of treatment for these conditions. But this is also important to look at the issue whether patients with these conditions are more likely to be prescribed antibiotics than the other patients. So that's why you need to have all patient data. The indication for antibiotic use, I'll come to that later, and the treatment, the actual antibiotic and indication, and whenever there is microbiology specimen, this is to be collected as well. I will not go through the patient form, but this slide is here to reiterate that it is for all included patients, and there is an aspect of core components and optional components. If you're participating, just carrying out the survey on your own, you can decide. But usually, if it's coming from above, from the Ministry for Health, for example, usually what's to be included and what's not is decided centrally. So it's not that one hospital from country A will include optional data and hospital B will not. So that's standardized at national level. The number of antibiotics, this is something which might not be collected in other methodologies. So the first part here in gray is if a patient receives benzoyl penicillin followed by ceftriaxone, the reported number of antibiotics should be 2. So if a patient received amoxicillin followed by amoxicillin and clavulanic acid, here it is also 2 because amoxicillin and coamoxiclav are not the same drug. Similarly, if a patient received ciprofloxacin, but treatment was interrupted for whatever reason, maybe out of stock issues, or the patient could not buy it, or they thought the patient was better and then developed a fever later, and it started after a few days, being the same drug, irrespective of route of administration. Here, the number of antibiotics should be 1 and not 2, because it's the same substance. It does not depend on the route of administration. Then there are the indication antibiotic forms. These are only to be filled in for patients actually on antibiotics, not for all patients, obviously, because if there's no antibiotics, there's nothing to fill. The inclusion-exclusion criteria are quasi-identical to the Global PPS. The special cases, I think, are the same as well, but I'll go a bit into more detail. Sometimes we find patients who are given a drug less frequently than once daily. For example, gentamicin every other day. If on the day of the survey the drug is not due, the patient is still on treatment because the patient took the drug yesterday and will be taking the drug tomorrow. So the frequency would be 0.5 because it's every 48 hours. If it's every 3 days, the frequency would be 0.33. Obviously, if a patient is on antibiotic A at 8 a.m. this morning, but the treatment changed to drug B at 10 a.m., only antibiotic A is to be reported because remember the snapshot, the photograph is taken at 8 a.m., not at the time you visit the ward. For surgical prophylaxis, you look back 24 hours, which is similar to the Global PPS. This is a summary of what I've just said about exclusion criteria. I will not go through it, but for your convenience, it's there. When you get the PDF form of these slides, it's a good summary, I think. And with respect to the surgical prophylaxis, when I come to the indications, I have a slide which will define better what I was speaking about here. So in this methodology, you have to use the INN for drugs. And so, for example, if it's amoxicillin and clavulanic acid, it's amoxicillin, clavulanic acid. It's not Comoxiclav. It's not any brand name. It's the INN that has to be used. The dosing unit should be reported as well, and this and the number of units per day, because this will help define your prescribed daily dose, which might differ from the WHO collaborating centers defined daily dose. With respect to antibiotic data, also there is an aspect of combination products, which I will discuss in the next two slides. So taking example one, co-trimoxazole, it should not be written as co-trimoxazole, but the product contains 160 milligrams of trimethoprim and 800 milligrams of sulfamethoxazole, and is given every 12 hours. So in the form, you will need to write trimethoprim, sulfamethoxazole. With respect to unit dose, it's 960, so it is 160 plus 800. The unit dose is in milligrams. The unit dose combination is 160 milligram, 800 milligram, and the frequency is 2. And the data has to be inputted in this way so that the WHO can evaluate it at a later stage. With respect to Comoxiclav, it is different because the name already writes amoxicillin, clavulanic acid. But with respect to the dose, you only include the dose of the active ingredient, which is the amoxicillin component. So it is 500, not 625. With respect to unit dose measure, it's milligram again, but unit dose combination, it's 500 milligram, 1 to 5 milligram. So in this case, both the antibiotic and the beta-lactamase inhibitor are included. And obviously the frequency is 3 times daily, so it's 3. Going to indication type, a slight difference from the Global Pps, where hospital-acquired infections are grouped as one. Then you can do the diagnosis, which can be a wound infection as opposed to a CNS infection, etc. But we don't have HAA1, HAA2, HAA3, 4, and 5, etc. So it's a bit simpler from this aspect. There's surgical prophylaxis, which is identical to, and medical prophylaxis identical to GPPS, and others and unknowns are classified as other. And for example, erythromycin used as prokinetic as a motilin agonist is one of such indications. The definition of medical prophylaxis, this is not does not include all possible indications, but the most common indications include prevention of opportunistic infections in immunocompromised patients, such as those on chemotherapy, HIV patients, patients with cirrhosis, prevention of UTI in patients with urinary tract defects. But I've seen other strange uses for this. For example, there was a case where one of the audience said, what about prophylaxis being started post-surgery? When a drug is used just in case, the clinician is not trying to prevent an infection. So that does not fall under medical prophylaxis. It should fall under treatment of what they're trying to prevent. With surgical prophylaxis, there are 3 options. 1 dose, even if it's a drug that's given once daily. For example, ceftriaxone is given as a once daily dose. But if it's 1 dose, you don't say 1 day, it's SP1. If it's multiple doses within 24 hours, that's SP2. So if it started, let's say it's Comoxiclav, started today at 2 p.m. Sorry, started yesterday at 2 p.m. This morning at yesterday at 10 a.m. and this morning at 6 a.m. In that case, it's 1 day. If it's continued further, it's more than 24 hours, so it's SP3. If it's started on the day of the survey, it is to be excluded. And this is a table I had helped in preparing for the Global Pps. And once again, it provides a summary of what's what. And the key aspect is if the antibiotic prophylaxis was stopped more than 1 day before the survey, it's not to be included. And if it started today after 8 a.m., it's not included. And once again, this is something helpful that people carrying out the survey should be familiar with. When it comes to surgical prophylaxis, the WHO PPS also refers to the site. So, for example, if you're doing a surgical procedure related to the urinary tract, you're preventing urinary tract infection. So you have to add UTI. The unknown aspect should be avoided as much as possible because it will make you none the wiser. If you start inputting a lot of unknowns, you will finish quicker, but you can do pretty much nothing with your data. So once again, I reiterate, if it's not documented what kind of surgery it was, ask the team, and usually will come to a conclusion that it is one type of these procedures and this list. The actual diagnosis, when there's treatment, there's various, and here I only included the abbreviations, but there's definition of each one in detail in the protocol. For example, respiratory tract, there's bronchitis as opposed to pneumonia, there's cystic fibrosis, so there, with respect to urinary tract, there's cystitis as opposed to pyelonephritis, and pyelonephritis, some people refer to it as urosepsis, and obviously an upper urinary tract infection is more serious than a lower urinary tract infection. With respect to antibiotic treatment, there's another slightly different slight difference from the Global Pps, where we have a start date for the treatment in the indication form and start date antibiotic for the antibiotic form. What is the difference here? So the start day of treatment refers to the first antibiotic used for the treatment of a current infection. Let's say 1 week ago, the patient was started on comoxiclav, but 2 days ago, the CNS report came in, or the patient was not improving, and the drug was changed to Piptas and vancomycin, for example. In that case, the start day treatment would be 1 week ago when the comoxiclav was started. But start date antibiotic, the antibiotics that the patient is on at the moment, would be when these antibiotics were introduced. So 3 days ago, as I said in my example. Indication count. So the indications are listed as 1, 2, 3, 4. Usually will not have more than 2, but you can list a number of indications. If the antibiotic cannot be linked to any indication, it should be kept empty, but usually, and you will find an indication. So this should be very rare. Once again, if you have unknowns, you cannot do much with your data except asking for better documentation. If there is more than one indication, and this question has arisen before, for example, amoxicillin used for both for urinary tract infection, cystitis, and pneumonia. Both 1 and 2 should be listed. Oops, sorry. So you put 1, 2 and the dedicated space in the form. Another aspect is that in the Global PPS, you don't look at the prescriber type, but here we do. And there are specialist physicians, GP. Now, GP does not necessarily mean general practitioner in the community. There are many medical officers who work in a hospital without an actual specialization or traineeship. So that's what's referred to here. Then there is other, because you can have non-clinical prescribers. So that's what other is referred to. Obviously, the unknown option is still there. Route of administration, I will not go into too much detail there. Missed doses, I will mention later, so I will not go into much detail. Guideline compliance, obviously, if you do not have any guidelines in your country, you don't try to say, okay, let me see if they're following any US-based guidelines. No, the guidelines have to be specific to your country, ideally to your institution. And treatment type, what the GPPS refers to as targeted here is referred to as directed, and empirical is the same. So directed is like targeted based on microbiology information. Empirical is based on the clinical diagnosis only. So going to the out of stock examples as well. So I have 4 aspects listed here, but I will go through the first 2, not to waste too much time on this. So if an antibiotic, A, amoxicillin, is unavailable for 3 days, it should be listed in the antibiotic out of stock list. However, if one particular product of amoxicillin is missing from day 1 to 5, but available on day 6, while another product of the same antibiotic is available in the different days, then if there's, so if product A and product X and product Z cover the total availability of a product, they should not be listed. But if there's a gap, and in this case there is a gap, then it should be listed. Missed doses. So as I was saying, in some countries, you can have issues with stock availability, issues with patient not being able to purchase the drug. So this is something that happens frequently, and in the few actual trainings I had with hands-on experience there, I've seen it that patients buy a number of doses, miss some doses, and they restart when they get sufficient funds to continue buying the rest of the treatment. There could be other reasons, and they could be multiple reasons. For example, if the patients are buying the drug from the hospital pharmacy, it could be that for one dose they missed it because it was not available. Then the next batch was more expensive and the patient could not purchase. So it would be a multiple reason. So it was not taken for multiple reasons. And all these items I'm mentioning here, I'm just skimming through them. Much more detail is available on the actual protocol. And as I said, the purpose of this presentation is to give an overview, not the full detail of the actual protocol. So here, if we take the last case only, if patient A on day 2, the second and third tablet were not administered because antibiotic was not available, the number of doses missed would be 2, and the reason would be S, stock out issue. The other 2 examples are there so that you can look at them, but I don't need to go into the detail of giving 3 examples for each of these examples I'm mentioning here. The microbiology form is mandatory, but from what I've learned between 2018 and 2019, because last year, obviously, because of the pandemic, things went a bit down the drain. Many hospitals that participated from low and middle income countries. Especially in this case, it was from sub-Saharan Africa. Very few hospitals have a fully functional microbiology lab. So they might have the lab, but they might not have the media. So very few C&S reports, for example, were available. Some percent pitfalls to look for. So with respect to data collection, it's important that the right details for the patient are entered, because if you need to go back and check data, you must be sure to be looking at the same patient files. Also, the investigators must be familiar with the files and diagnosis. As I said earlier, often the diagnosis is not written as per our case definition or pneumonia. So as I said, if it's lower lobe consolidation from a chest X-ray, the auditor must be able to interpret that as a pneumonia. If nothing is written whatsoever, ask the ward staff. As I said, you shouldn't intervene, so you shouldn't say, I don't think this is the right drug, you should switch to that. No, but you can ask what the treatment intent is. With respect to data entry, once again, right details must be submitted, and the officer inputting the data, which might or might not be the same person who entered the data on the paper forms, must be able to read what you've written. So some people, pointing fingers at the undersigned, have very illegible handwriting. It's important that you try to write legibly to make the life of the person entering the data less difficult. If the person entering the data on the software is not sure what is written, it's important that they ask. And that's why you need to know who the auditor is. Obviously, if you input erroneous data, erroneous output will come out. So that's important across the board. This I've already mentioned. At hospital level, if you're participating as part of a country initiative, at hospital level, there is nothing which is optional. That's decided at the central level. Some aspects of the forms, I will not go into the detail about the forms, but at hospital level, the total hospital beds as opposed to the hospital acute beds is not always the same, because you can have day case beds which would not be included in the acute beds but would be included in the total beds, or you might have a long-term care ward. So those are not part of the acute beds. So these two are not the same. Also, hospital included patients and eligible patients. In large hospitals, according to the WHO methodology, you can sample patients, as well as in some countries there is either a consent form from the medical director or a consent form from consent request from the individual patient or carer. So the number of eligible patients and the number of included patients might vary even from that aspect. So an eligible patient might refuse to participate. So it's not a standard that each patient needs to endorse, but if at national level they decide that each patient needs to approve participation, then the number of eligible patients and the number of included patients will obviously be different. At ward level, the same, total patients and eligible patients might not be the same, as well as eligible patients and included patients for the same reasons I've described earlier. With respect to patient details, I know the slide on the left-hand side is not clear, but the aim is not to go into the actual forms, but the top part would be mandatory fields, the bottom part would be optional fields. And as I said, there's nothing optional at hospital level. With respect to age, there are 3 fields: number of days in neonates, number of months up to 2 years, number of years over 2 years. You only fill one form. So you don't say 3 years, 2 months, 5 days. If it's 3 years, it's 3 years. The months and the days are not important. If it's a neonate, 1 day as opposed to 27 days make a big difference. If it's a toddler, so from 1 month to 24 months to 23 months, you write the number of months. And this is explained in the protocol, as I said, but just some notes to keep in mind. Something I've seen is sometimes they fill the surgical prophylaxis duration without the indication being surgical prophylaxis. So it does not make sense. I reiterate, as much as possible, avoid the unknowns. And I've also seen auditors missing data or forgetting to input some of the data. It's important that you have complete data, otherwise it's virtually a waste of time if you have a lot of missing information. Some examples from experience. So these were 2 hospitals that participated in a pilot, and in the adult ICU, the eligible patients was listed as 3, and included patients was listed as 7. Obviously, these should have been the other way around. So that's important that the data is entered correctly. Here, once again, highlighting the issue with blanks and unknowns. Here we have 2 the same hospitals. The second hospital left a lot of blank data, which could be anything, and hospital 1 had a lot of unknowns. And with all those unknowns, it's a bit used as the data. Obviously, in the case of patients admitted to medical wards, this is about the type of surgery since admission. If the patient is not a surgical patient, the answer should be not applicable. So blank and unknown should not be listed, should not be marked in your data. This is another example. So surgical prophylaxis without a site, or completely undefined site with no systemic inflammation, and then listed as community-acquired pneumonia. I mean, these kind of data highlight issues with data collection and/or data entry. I mentioned this already. It's important that each auditor carries out a pilot phase so that they know what they are meant to collect. And an example would be that the same 10 patients are assessed by all auditors, and then compare the outcome and see if there's congruency or there's differences between the results. And obviously, if there's differences, the gold standard, the team leader should clarify what's meant to be collected. And in this way, carrying out a pilot phase, it will minimize the blanks, the wrong data being entered, and similar errors.
Peter, just to say, if we can go for another 5 minutes so we can take some questions as well. Thank you.
Get specialists on board. So if you're doing pediatrics, get a pediatrician on board. Use all sources of information like file, treatment chart, admission book, or whatever kind of information there is on the ward. Investigators must receive the protocol and the data collection forms well in advance so that they are familiar by the time. As I said, currently antiretrovirus, etc., are not collected, but it might be in the future. Last 2 slides. What's most important is good communication at national level. So the national team with the hospitals, at the hospital level, the hospital team with the wards. And now it's time for the Q&A. So I was not looking at the chat, so I'm not sure what the
No problem. I can, that's fine. Anna's also been answering some questions, which is really helpful. So if there are any questions the colleagues feel have not been answered, again, if you can recopy and post them, I'll ask them to Peter. So just one from Adita here. In case of standard fixed dose combinations like for tuberculosis, do we define every antimicrobial or just the FDC and the WHO ATC code?
At this point in time, anti-TB therapy is not included because there's a different network for tuberculosis surveillance within WHO. But in the future, it should be, it should be all items as listed in the WHO Cooperating Center. So if it's ethambutol, isoniazid, rifampicin, I don't know how they're listed.
So thank you, Peter. For the GPPS, where they do collect, they use the code. So for example, J04AM05 is rifampicin, pyrazinamide, and isoniazid. So Anna's answered that in the chat. There's a question I saw here about Comoxiclav, 8 hourly, which was from pharmacist Lake, I think. In the UK, Comoxiclav is 8 hourly for us. Is it 12 hourly in some countries?
In Malta, we have both options depending on the dosage. And I'm speaking about the oral. The IV is always, in Malta, is always 3 times daily. Obviously, I'm not speaking about renal insufficiency where you need to adjust dose. I'm speaking about the standard dose. So in Malta, the IV is always, the parenteral is always 3 times daily. With respect to the oral formulations, we have those that are 875 milligrams or more of amoxicillin can be used twice daily. For example, Comoxiclav 875-125, often referred to as the 1 gram, that can be used either twice or 3 times daily. Now there are other formulations which are 1 gram of amoxicillin and 1 to 5 of clavulanic, which are only intended for twice daily use.
So I think the summary is it depends on your country and depends on what formulations you have available.
Yeah, and the ratio of amoxicillin to clavulanic.
Yeah, so it's about the
7:1, etc.
Yeah, thank you. In situations where most patients receive surgical prophylaxis during or immediately after surgery, how can this be recorded?
Actually, during, if it's a stat dose, it's a stat dose. Technically, it should be started before the first incision because clinically it's useless if it's administered after the incision. But that aside, if the procedure was carried out yesterday, if we're carrying out the survey today, if the procedure was carried out yesterday at noon, for example, and the drug was given any time between 10 a.m. and 10 p.m. yesterday, that's included. Now, if it's a stat dose, it's SP1. If it's 24 hours, it's SP2. If it's more than 24 hours, that is, it's intended to be continued today and possibly even tomorrow and thereafter, it's SP3. So it's more than 1 day. I don't know whether that answers the question.
Yeah, I think that should be fine. If it's not clear, please do feel free to add again into the question. So there's one here. What if the microbiological report has been telephonically communicated and the actual report will be sent in a day or 2? I'm assuming the question is, how do they record that?
Well, if it's been reported
If I just ask you to speak up a little bit, sorry.
If it's being reported verbally, it should be somewhat documented in the minutes in the patient file. If there's no evidence whatsoever, I mean, but somebody tells you, listen, the microbiology lab called us and they told us there's E. coli susceptible to comoxiclav. Well, then ideally you should either log in into the laboratory information system if it's available and get the information from there, or jot down the information and fill in the information accordingly. If you do not have access to the actual CNDS report, either verbally or soft or hard copy, then probably it would be best to eliminate, because it's just by hearsay. There's no evidence of the fact.
So, Peter, just to summarize, what you're saying is that if the person completing the form has the information directly from the lab, verbally, they can record it down. Or if within the notes, somebody has said the microbiological lab has called us and said X, Y, and Z, that's also recorded in the notes. So that's fine to also include. Is that right?
Yeah.
Okay, thank you very much. So there's a question about antimalarials and ART. Are they recorded in WHO PPS? I think this is a common question.
So highly active antiretrovirals and
Sorry, your voice is low again, Peter. Sorry.
highly active antiretrovirals, antimalarials, anti-TB, for the time being. It might be that in 2022 it will change, because the idea is to go to, like the CDC, a 5-yearly, every 5 years there will be the survey running in a country that has decided to participate. It might be that in the future, it is actually likely that in the future they'll start being recorded. But for the time being, it's not recorded. So ART is not recorded.
Yeah. So ART, antimalarials. Oh no, is that anti-TB not recorded? Antimalarials?
No. Anti-TB, antimalarials, and highly active antiretrovirals are not recorded.
And not recorded
No.
in WHO PPS,
No.
but they are recorded in Global Pps.
Yes.
We'll go through this again, and when we go to the slides, it just talks about the summarizes the similarities and differences. We've got people saying thank you for wonderful sessions. So thank you again to Peter and to Anne for really great presentations. Really grateful for that. And we will move on to the next session now. So I was just checking to see if there were any further questions. We'll move on to one more session and then we'll go into the break. And so the next session is around just trying to summarize. And Kieran, I think I'm happy to share my screen for this, or if you share the screen, if you had a chance to update the slide, you can share the screen and I will just tell you when to move to the next slide. So we're going to now just really to try and summarize the differences and similarities between the Global PPS and the WHO PPS as an opportunity for us to just consolidate the information. As we said, the aim here is not about which you should use. Our aim is really to just highlight the nuances between them for you. So before I go into my presentation, just to check that you're all still awake and with us, please just type into the chat very briefly what you have taken as the key similarities between WHO PPS and Global PPS. So if you can just type into the chat very briefly, the key things that you think, well, this makes it very similar, and these are the key differences. We'll just take a few and see what people say. If I can have a slideshow on that, please, Kieran, thank you. So just waiting to see if some chat into the, so just anything that you think are similarities or differences. Kieran, I think we've gone to the beginning there.
Yep, sorry, Dan, just changing it now.
That's fine. So we'll just wait and see what people have shared, because I think this is really helpful, and it's thank you, Marcino. That's helpful. So Marcino has said WHO, no anti-TB, no malaria treatment, also no ART, no antivirals, or no antiretrovirals. And so the focus is around antibiotics. Any more thoughts on similarities and differences, please? The aim here, yep, GPPS is voluntary. So yes, you can at any time access the GPPS and complete it. Whereas the WHO, it will really be, you can use the tool if you want to, but you do need your ministry to identify hospitals. You may want to volunteer to your ministry and say you would want to do it, but they may have a process of randomizing hospitals as well. Okay, so they're coming fast now. Yep, so WHO needs to be invited. So haven't used WHO PPS yet, but looks similar. So in reality, both of them, Global PPS and WHO PPS, have their original history in the ECDC or ESAC PPS from many, many years ago, although they've obviously both been adapted for the different contexts. For countries without national support, GPPS seems a better tool for individual institutions. I agree. So I think, there's something around, if you're looking at your individual institution and you're wanting to develop your interventions, then you need to really try and think of what gives you that tool. There may be possibility for you to use, when you collect information from one, to see how you can adapt it and put it into GPPS if you want that automated feedback. They really present you with slides ready for you to present to your clinicians and to be able to make decisions. Global PPS for all countries, WHO PPS low income. I would say that WHO will probably say that that's not 100% true. I think WHO PPS has taken more into consideration LMICs, but I would believe that they would think that it's for any country to be able to use. But you're right that there, things like missed doses is quite important and quite the reality. And so those are the kind of information that's not available in Global PPS, but is available in WHO PPS. So for all the PPS, they all start at 8 a.m. at start time. Exactly, that's true. WHO PPS needs consenting of the patient. Peter, just help me with that. Is that true? Peter, you're on mute. Do you need consent from each patient for WHO PPS?
No, but some countries, when we were asking, they said they mentioned this as a possibility. So it's not that it's there. Usually it's coming from the medical director, and that opens the floor. But there can be situations that it can be on an individual basis.
So I would struggle with that concept, and I would say that, as Peter said, it would be maybe a hospital level decision, but this may be where you need to go through the ethics team. It's quite difficult if you've got patients in ICU. How do you get consent from them? So there may be something that needs to be done from an ethics review point of view to be able to work through that process. So similarities, survey objectives, GPPS, individual hospitals can participate. GPPS more comprehensive for healthcare-associated infections and biomarkers. So yeah, that's a really important point if you want to look at your healthcare-associated infections. And I know that they've also added COVID as an indication as well now. So those are some of the things that you need to consider. Thank you for the presentation. For those of us in private hospitals, embracing GPPS is an awesome tool for QA and QC. I'm assuming you mean by QA quality assurance and quality control. Totally agree. Quality improvement and also developing of interventions. Someone said, yeah, the survey should be done on the weekdays and holidays and weekends excluded. That's true. So another question, biomarkers and HAIs, they're not on the WHO PPS, are they, Peter?
No, they're not. And the rationale, because I had suggested that when we were writing it, and in LMIC countries, it's a bit less common to have procalcitonin and CRP reported routinely.
So this is about the biomarkers that are available. Yeah. So WHO is good for countrywide multicentric surveys with I really agree. So if you're thinking about, the way to think about it is if you want to know your national data, although you can also get that through GPPS, But if you really want at a national level and also reporting through WHO and reporting globally through a central reporting system, it is important to participate in WHO PPS. But again, that's, you know, from a ministry level. So for colleagues who are within the ministry that are attending today, hopefully you're seeing the differences and how both tools can be used. So you may want to assign some to WHO, but it's a discussion that needs to be had within the country. So Aditi also says, GPP has become very standardized, though, a common name in any antimicrobial stewardship program. I won't read the rest of that up. Yeah, thank you. Okay, so thank you so much for contributing to that. Thank you all so much for contributing to that session. So I think I've got, how long do I have for this next session? So I have another 9 minutes to just go through the slides we have, and there are very few slides, and actually you've all picked up a lot of the key points. So someone here said, is it possible to merge both tools such that depending on the level of institution, one platform is what we use for all? I don't know that we can merge it in a way that, you know, goes across both of them, but there may be possibilities, and we're discussing this, that if you've participated in, definitely I have to be careful how I say this, if you've participated in WHO PPS, it may be possible to enter some of your data into Global PPS platform so that you have that feedback that you need in your hospital for your local interventions. I doubt we can do it the other way around. So if you participated in Global PPS, I doubt you'll be able to go to WHO PPS platform. Peter and Anne, correct me if I'm wrong on that. Yeah, so Anne has reported and said that in Europe, they integrated the ECDC PPS, which is equivalent WHO PPS, but for Europe, they integrated it into the Global PPS platform so that individual organizations could have their feedback data. So yes, that is a possibility that way. I doubt Global PPS.
The other way around,
the other way is not possible. Yeah, that's fine. Okay, so very quickly, next slide, please. Kieran. So in terms of general principles, you all also highlighted the voluntary basis for Global PPS, whereas with WHO PPS is that country level, Ministry of Health or WHO country office. The importance of healthcare-associated infections and resistance patterns, whereas WHO is focused much on the antimicrobial use, and there are very simple quality indicators. And with the Global PPS, there's a stewardship tool. You can look at your indicators. You can get immediate feedback to your prescribers after you've validated the data. That's really important. And it says no informed consent at a patient level, whereas with WHO PPS is saying you may need informed or written consent. But that is really about what your country wants you to do. So that's that's country specific. Next slide. And in terms of the protocol and data management, both of them have got standardized protocols, and you collect detailed data on all patients under surveillance for WHO PPS. However, for Global PPS, you collect patient characteristics for admitted patients. So it's slightly different in terms of who you collect data for between Global PPS and WHO PPS. And there's an online IT platform for the WHO PPS as well, so you can put your data on there. And the data storage can be at a hospital or national level. With the Global PPS, again, there's a web-based tool. There's a quality assurance approach, data validation process, and it's really important to build that in. And then the data storage is at the University of Antwerp in Belgium, but you can use it to create your own database, and the hospital remains the owner of their own data. Next slide, please. So in terms of feedback and reporting, the responsibility for data management and retrieval is at the hospital level. Feedback is not automated. So by that, we mean with the Global PPS, once your data is inputted and you've validated it, you get a automated slide set, and I think and also spreadsheet that just analyzes your data and provides it. So it's an easier way for you to present back to your prescribers. Again, with WHO PPS, you can get feedback, but it's not once you enter the data, if that makes sense. Next slide, please. Peter and Anne, do feel free to correct me if I've got any of these slightly incorrect. Both of them have detailed information for inpatients. However, for Global PPS, the focus is on patients that are on antimicrobial that have antimicrobials prescribed only. And for WHO PPS, it's all patients that you collect patient information on. Okay, but very similar detailed patient information should be collected for both. Next slide, please. And then in terms of sampling, with Global PPS, there is no sampling on your first participation, but subsequently you can focus on ward type. So not so much patient sampling, but on ward type. So you can say, for example, first time you collect for all the wards, and then next time if you want to follow up, maybe because you've decided that you want to focus on surgery or you want to focus on medical wards, then you can focus on just those wards subsequently, and you get your data back to allow you to have a longitudinal follow-up. But you do not sample within the hospital or within a ward or within patients. Whereas with WHO PPS, sampling is at patient level. So if you have a hospital with 500 to 800 inpatient beds, you can decide that you will only include 1 or 2 patients per ward. But the decision about the sampling needs to be taken at a national level by the Ministry of Health in the first instance. I really encourage that people collect data systematically and throughout, and so that's certainly what we try to do in the UK. But and the reason for that is it allows you to but again, you know, remember with WHO PPS, it's about country level data rather than individual hospital data, and that's where there is a difference and why sampling may work for one but not the other. Next one. So in terms of therapeutic groups, we've gone over this over and over and over again. So hopefully you all remember now that with the Global PPS, you can include antibiotics and other drugs used for TB, antimalarials and antivirals, as well as antifungals, not topical use. For both of them, topical antimicrobial for topical use is excluded. And for WHO, you do not include those antimicrobials because they have other networks that collect the same information. So there may be a way to be able to collect the two together somehow, or merge to have the information that you need. Just something I forgot to mention earlier, if you're on social media or Twitter, please feel free to tweet any of the information you're learning using the hashtag CWPAMS. Next slide, please. So this is just an opportunity if there are any final questions on this session, and then we'll have a short break. And during the break, we'll share different information within the chat, so do feel free to just keep an eye on there. But the main focus is for you to have a break from the screen for a few minutes, and then we'll be back. So I'm just going to see what question we have here. So there's a question, which is best for hospitals to use if you want to begin? The simple answer is, if your Ministry of Health has not asked you to participate in a PPS, then Global PPS is the only one you have an option to use. Having one tool is important. I do think that the tools are independent and has served different purposes. And so, yeah, and they serve different purposes. So, could these data collection tools be employed for research purposes? Yes, in terms of if you wanted to do some research, potentially, but you would need to go through a full ethics approval if it's for research. So obviously, when hospitals are using Global PPS, and we're using Global PPS in the context of CWPAMS, we are using it for the purposes of service improvement, quality improvement within the hospital, not generic research. We are trying to ensure that our service to our patients in those hospitals is what we're trying to focus on. That's certainly the point for global PPS. WHO PPS in a way is similar, but it's trying to do it at a national level. How do we assure data security? So when you enter data into the either of the platforms, you are not entering patient identifiable data. So you cannot link the data back to an individual patient. But obviously, you're right in terms of the data for your institution, and the Global PPS team have really strong data sharing information and data security information. And I believe that WHO will have the same as well. It'll be helpful to know what you mean about data security. Is it that you're worried about your hospital data leaking, or is it about individual patients? So that's the question. So that's a further question on that. Let's have a look if there's any other questions. So certainly, we're talking about yes, if your hospital institute does not have an antimicrobial stewardship program, this is a perfect time to do this, because actually it gives you, and we'll talk about this in the next session, so do join us after the break. We talk about how you can develop interventions for your hospital to allow you to start a stewardship program. We also WHO also has a antimicrobial stewardship healthcare facility assessment tool, which you may want to use. And WHO has just literally in the last week published an antimicrobial stewardship policy document, which is also really useful and includes the healthcare facility survey that you can use to assess your stewardship and identify where your key areas of focus should be. I will put that into the chat shortly, so you have that information. Many countries have data security laws in terms of transmitting. Okay, fine. Again, so you will need to work through that process within your hospitals and within your countries. What sort of feedback is provided following right? Okay, so do you mean Global PPS or WHO? For Global PPS, in the next session or the afternoon sessions, we will give you examples of the feedback data you have. And we'll in fact ask you to become stewardship experts and try and develop interventions based on the feedback. So Ines and I will present to you as the data collectors, and then we'll ask you to become the Antimicrobial Stewardship Committee and highlight where you would want to focus attention for your hospital. Okay, who's responsible for data analysis? So for the Global PPS, it's done for you automated through the system. So you get your feedback data. For WHO PPS, Peter, what happens with the data analysis? I don't know.
So currently the data submitted for the first wave, is being analyzed at headquarters. And there will be a more of a formal report, generic report. So it will not be the individual reports, which are also being worked upon, but there will be a formal report on the number of countries and hospitals that participated and what the outcome was. It will be blinded, so there will be no reference to the specific countries which did better or worse. But there will also be similar reports to the country headquarters, to the country Ministry for Health with national reports, and possibly, I'm not sure about this, possibly even individual hospital reports. But the first report will be available in September of this year. At least I had a conversation with the WHO headquarters last week, and that's what they said, that by the end of September, there will be the formal report, which will be in the public domain. And then there will be the country reports and individual hospital reports, which will be close to the respective countries.
So can I check, when was the first wave done?
No, this is the first wave.
When was that done? When did people collect data for the first wave?
Actually, it started in 2019, and I know Tanzania participated with a convenience sample. There were, I think, about 10 countries in total. I'm not involved in the data analysis of
That's
this.
fine. So, yeah.
But I was involved until the pilot, which was done in 2 hospitals in Dar es Salaam and Tanzania. Then this was extended further to, I think it was something like 8 or 10 countries, Anglophonic and
Thank you.
Francophonic countries in Sub-Saharan Africa.
Thank you, Peter. So for those who collected data in 2019, the overall report will be available at a global level in September of this year. And then after that, they will get the country level data back to the ministries. And I know Peter said he wasn't sure about hospital level data, but there may be some hospital level data from the data that was collected in 2019 provided afterwards as well to countries for possible dissemination.
It was started in 2019. Most hospitals participated towards the end of last year. And obviously everything was
paused because of COVID.
Because of COVID. So there were major.
I think the main question was basically what the feedback, so that's what I was trying to get, is that from a WHO point of view, it's the feedback comes back together globally and then nationally. And with the Global PPS, you get your own feedback as you enter the data and you validate the data. And I think obviously with the WHO PPS, you have your data, so there's nothing stopping. Well, potentially hospitals can analyze some of their data to be able to develop their interventions should they wish to.
Yes, of course. What they cannot do at that point is compare with other hospitals.
Yeah.
Where the Global PPS will give you the feedback comparing to the region, etc. So that's a difference. But the idea is also that the platform they used to use Epicenter, now it's RedCap. No, EpiConcept. Now they're moving to RedCap. It's an IT thing. So the reporting will be more rapid because there will be it will not be as automated as the Global PPS system is, and the WHO does not communicate directly with the hospitals. So it's always communication is always directed at national level between the WHO country office and or Ministry for Health to the regional office and the headquarters in Geneva.
So for those who so Peter highlighting there that WHO focus is their communication is at a national level, so that data will always go back to the Ministry of Health first, and also that's similar with the ECDC. So the European level data that's been going on for many years is that that when the report is published, it's published at a European level, European Union level, European countries level. But what we used to do within the UK was also to provide individualized. So I also have a role within the National Institute for Public Health, and we lead on that for Europe, and we provide hospital level data back to them. But that's something we did separately. So this is something that ministries of health or public health institutions may want to discuss with their ministries of health about. Okay, we've run over my session now, and we need to have some time for break. Can I suggest that we take a break now, please, and that we are back?
Diana, can I still add something, if you don't mind?
We're 10 minutes over.
Okay. You don't mind, because I don't mind to respond to the person who asked the question, how do we assure data security? Because this is a really important issue.
Can you put it in the chat? I'm so sorry, Anne, but we are...
Or maybe we come back later, no problem.
Maybe actually in the Q&A session after the break, that's another opportunity.
Yeah, so very good, thank you.
Go on a break now, please, and that we're back at 12:10, please. So 10 minutes past 12. So if we have a 10 minutes break, I recommend that you stay on the platform, but mute yourself and keep your cameras off as they are, and just have a break. We will not be talking again until 10 past 12. But feel free to type things into the chat. Kieran, is it possible to just have a slide that says on break back at 12:10, please?
Yep, just putting that up just now.
We'll get started shortly. I know some people left and we've just got people coming back into the waiting room. Kieran, is it okay if I share my screen, please?
Yeah, sure.
Well, we're going into the Q&A session now. So this is an opportunity for you to ask any further questions. And you know, we've had quite a bit of time to ask questions and to interact through the last couple of sessions. But if you've got any final questions, you can put them into the chat. Just before we do that, I mentioned the WHO. There was a question from a colleague on the line about if you haven't done antimicrobial stewardship before, what do you do? So I just wanted to quickly highlight this new WHO guidance on integrated. Can you all see my screen?
Yeah, we can see it.
Their colleagues in the waiting room, please, co-hosts. So WHO policy guidance on integrated antimicrobial stewardship activities. This is really focused on the on national colleagues or colleagues in the ministries of health. But one of the key points I wanted to just highlight is that towards the end of the policy, which focuses on national activities, towards the end of the policy, there are some assessment tools. There's one for national level assessment, and then there's one for healthcare facility assessment. The healthcare facility assessment is the one that was published, I think, in 2019. And so you can use this at a healthcare facility level. So you need to choose which of the tools you want to use. So there's a national assessment tool, and then if you scroll further down, there's the hospital or healthcare facility assessment tool. So this is an opportunity for you to decide if you want to focus on, basically you for each, so it's an opportunity for you to assess your overall stewardship activities within your hospital. That's what it's there for, within your healthcare facility. And then you can decide, you know, what level you're at a baseline. You know, has it been identified by the management leadership? No. Planned, not started, partially implemented, fully implemented. So there's a whole range. And within that, is a section on surveillance activities or AMS actions and monitoring of data, and education and training as well. So really, monitoring and surveillance really gives you an opportunity to be able to look at your overall healthcare facility and then identify your key areas for action. So for example, if you are the baseline now where you haven't done any regular audits, but by the time you get to next year, you've started to use either of the PPS, you'll be able to move on and say, now a priority, partially implemented, and things like that. So I hope that helps for those who have not started any stewardship interventions yet within your hospital. It's a really good way for you to understand where to start from and where to focus your attention. Okay, so I'll just see if there are any further questions. Okay, can we have a brief discussion about diagnosis, as there are some query with cystitis, pyelonephritis, I can't remember what BAC is, sepsis and PUO. So, okay,
maybe this is from the Global Pps. I see cystitis is referring to a lower urinary tract infection, to be distinguished with PA, the upper urinary tract infection, referring to pyelonephritis. So we make the distinction there. Sorry, and then there was further BAC is referring to bacterial infection, to be not confused with sepsis, where you have all the symptomatic clinical appearance of sepsis. A true sepsis, a bacteremia is really that you might discover that you have discovered a microorganism through a hemoculture. So you make a difference there also. And what do we have more? Can this be used for, okay?
Eva, I think that is that question for the WHO policy rather than Global Pps.
I think in the WHO they have similar coding. I do believe that. Yeah.
No, I think her question. Sorry, I think her question was, Eva, if you can please type into the chat in your question about can this be used for assessing AMS at an outpatient setting? Are you referring to the healthcare facility assessment or to the PPS tools? Yeah, for the policy, that's fine. I'll come back to that, Eva. And are you finished in terms of answering the diagnosis question?
Unmuted. I think it's right. Peter Zout also mentioned that pyelonephritis is often referred to urosepsis. It is right. And that sepsis as a code is sepsis can be any or unknown origin. That is right. Yeah.
Okay.
Anyway, in the diagnostic list, it is more explained in detail. There are examples given, and also in the frequent asked question list, there is a whole enumerations of diagnostic codes and diagnostic diagnosis. How would you encode them? So we have those lists also in the frequent asked question list available on the document side of the Global Pps. Yeah.
Okay, thank you, Anne. I'm just going to go back to the policy document again, because I think there was a question on that. So, and this is really important, especially for colleagues from the ministry who are wanting to look at the antimicrobial stewardship activities at a national level and then influencing the colleagues or influencing hospitals and healthcare facilities. And again, the PPS that we've been talking about, which is surveillance, all fits in within this policy, which has been published. So I think, Eva, your question was that, has this been, can this be used for outpatient settings? So the answer, and I'm assuming you're talking about the assessment tool, yes, is the short answer to that. But you'll need to be you'll need to be mindful that some of them may not be directly applicable to an outpatient setting, but there's nothing stopping you from using the assessment tool. So remember, it's a self-assessment tool for you to consider different activities that you may wish to carry out. So, for example, it talks about leadership commitment. Is stewardship identified as a priority within the leadership of that facility? And then again, is there dedicated financial support for stewardship? Then you move on to accountability and responsibility. Is there a stewardship committee or group? Obviously, if it's a small outpatient setting, that may not be possible. So again, there is an option for you to put no, not yet, no, but not a priority. Sorry, no, but it is a priority, planned and not started. So you may say no, but within your hospital, you will know why the answer is a no. And then again, I'm going back to antimicrobial stewardship actions. So once you have collected your data, are you feeding back information to prescribers and to teams? And then education and training, the different activities, and then monitoring and surveillance, which is where we have focused our attention today. In terms of the point prevalence surveys, there is one here around our regular prescription audits, point prevalence surveys to assess appropriateness of antibiotics undertaken at the facility level. And then does the healthcare facility regularly monitor shortages and stockouts of essential antimicrobials, as an example? So hopefully that answers your question. I'll see if there are any further questions on this. And then again, at a national level, so apologies, at a national level, the tool, there is also an assessment there, and its example, is there national policy for integrated stewardship activities? Is there central national coordination unit? And again, there is also a surveillance section within the policy. There's a section on stewardship guidelines and tools, and then there's a section on ensure access to and regulation of antimicrobials. So that's all about legislation, all about important access to antimicrobials. There's a pillar on improving awareness, education and training, participating in WHO World Antimicrobial Awareness Week. And there's one on strengthening links to WASH and IPC, because that's really important for AMR, not asking stewardship teams to lead on WASH and IPC, but ensuring that there's a cross linkage between the two and leveraging those collaborations. And then the pillar 5 is around surveillance, monitoring and evaluation. So are there guidelines stated, and is there, let's have a look. So is there national surveillance program for antimicrobial resistant consumption and use with defined structures, for example, and then monitoring and evaluation of your stewardship activities. So I'll stop there now. So hopefully that answers the questions. I can't see any other questions in the chat. So I am assuming that that is okay. Okay, so if anyone's got any other questions, please continue to use the chat functionality. If not, we're going to move on to the next session now, which is more an example of feedback data that you would get back from Global Pps. And the aim here is really for us to have some hands-on practice at developing antimicrobial stewardship interventions. But I'm going to hand over to Ines first, and then I will come back in.
Yes, thank you, Diane. I hope you can all see my screen.
Yes, we can. Thank you.
Okay, perfect. Okay, so hello, everyone. My name is Ines Pauwels, and together with Anne, I work on the day-to-day coordination of the Global PPS project. So in the previous sessions, you have heard everything there is to know about the point prevalence survey methodology and on how you can go about it and collect data in your hospital. But then, of course, indeed, the next step would be to go and take a look at your results and to
use them to inform stewardship in your hospital. So that is what we will talk about here. And I will just start by showing you what the output looks like for Global PPS. And so as Anne already mentioned actually earlier, there are many different possibilities of getting your data once you've entered them online. So the first option is the export of the Excel file. And so this can be particularly useful, for example, if you go and export it right before data validation, so then you can do a cross-check of all the patients, are all the patients' information entered, are all the prescriptions entered, and then you can proceed to data validation. And then afterwards, you can use it as a database in case you would like to do your own analysis. And so the Excel itself, we have made it so that it is as easy as possible for you to do your own analysis. We've added some extra variables, such as the ATC code and the aware classification to help you with that. And I will talk a little bit more about the aware classification later. But then, and I think this is also important to know, is that we have the feedback reports in PDF. So what happens here is that once you have entered all your data, once you have validated the data, you can go online in the application, and then you can generate a report. And then in the background, a statistical software program calculates the results for you. And then this feedback report will be sent to you by email in the next couple of minutes. So what you will have then is a full report in PDF, which lists your most important point prevalence survey results in a set of graphs and tables. And so it will have your own hospital data, but it will also have the benchmarking data. And so by benchmarking data, we mean the data of your country, of your continent, or of the same hospital type, for example, all tertiary hospitals within your continent. And so you can use this data for comparison. And so this report is actually developed to support local communication of your point prevalence survey results. So you can use it if you would like to present your PPS results, for example, to the hospital stewardship committee. And so, as Anne already mentioned, the feedback report has many different, comes in many different formats. So the most important one is the 1-point feedback. And we call it the 1-point feedback because it's already available for you after you have participated in Global PPS once. And so you can go and download it. And then we have the longitudinal feedback, which becomes available to you as soon as you have participated more than once. And so you can see the evolution of your results over time. And then finally, if you participate with a set of hospitals, you can go and download a merged feedback report, which will then show you the aggregated results for all your hospitals. And so in the next couple of slides, I will just show you some examples of what these reports look like. And then we will go further to how you can use them for antimicrobial stewardship. So this is a first example of a slide, so a page in the 1-point feedback report. I hope you can see it clearly. I will just walk you through it. So it shows the antimicrobial prevalence on adult wards for a certain hospital. As you see in red, these are the hospital data. And so for this case, for this specific hospital, you see that they have a hospital-wide antimicrobial prevalence on adult wards of 43.5%. So that means that at the time of the PPS, 43.5% of the admitted patients were on antimicrobials. And so then you have it for the entire hospital. And then as you can see, you have it also by ward type. So AMW means adult medical ward, then we have hemato-oncology, adult medical ward, and so on. And then below that, you can see the benchmarking data. So for country, continent, and hospital type. On this slide, it's a little bit the same principle, but a little bit more detailed in terms of classes of antimicrobials. It's for another hospital. Here you can see that the overall antimicrobial use prevalence is higher. It's 67.1%. And here you also have it split up by antimicrobial group. So as we talked about this morning, Global PPS also surveys anti-TB, anti-malarial, and antiretroviral drugs. So these prevalences, you can find them in the report as well. And then again, you have the benchmarking data. Okay, so this is another example which gives you quite some information, more specifically on the quality indicators. And so again, you see the hospital results marked in red. And the quality indicators, they are reported by activity here. So we have medical wards, surgical wards, and ICU wards. And then for each activity, you have the respective quality indicators related to antibiotic prescribing. So reason in notes, that's the percentage of prescriptions with a documented reason in the patient notes. Guidelines missing is a percentage with a missing guideline. Guideline compliance, I think that is pretty straightforward. And then stop review date documented. This is the percentage of prescriptions with a documented stop or review date in the notes as well. And so then you have the benchmarking data again. Yeah, so we recently also added in the report a series of slides where we use the WHO aware classification to visualize patterns of antibiotic prescribing based on PPS results. And so before I show an example of such a slide, I will briefly explain a little bit what the aware classification is for those of you who are not familiar with it. So a couple of years ago, the WHO released the aware classification where they classified all the antibiotics that were available worldwide into 4 categories based on their role in first or second choice for certain infectious syndromes, and also based on their risk of selecting for resistance. So the first category is the access category. This includes the first or second choice antibiotics for empiric treatment of the most common infections, and they generally have a lower risk of resistance selection. So for example, amoxicillin or cloxacillin are access antibiotics. Then we have the watch antibiotics. These are the first or second choice antibiotics for limited indications only, but nevertheless quite important antibiotics. But they generally have a higher risk of resistance selection. For example, the quinolones, the carbapenems, and the cephalosporins of the second and third generation are all watch antibiotics. And then finally, we have the reserve antibiotics, and these are the so-called last resort antibiotics, such as colistin. And then at the end of 2019, a 4th category was added by WHO, and this was the category not recommended. And so this category includes mainly fixed dose combinations of broad spectrum antibiotics that are not actually recommended in clinical practice. And so with this in the back of our heads, I will just show you the following slide. This is an example again of a feedback slide you get after you have entered Global PPS data. So this is a slide specifically for pneumonia. You see for this hospital, I don't think you can read the percentages, but I will read them out to you. So in this hospital, 65% of all the antibiotic prescriptions for pneumonia were for watch antibiotics, and 35% were for excess antibiotics, and there were no reserve antibiotics in this hospital. And then again below, you can see the benchmarking data. If you participate in the optional healthcare associated infections module, you will get some additional slides, such as this one. So for the optional healthcare associated infections module, we focus on the presence of invasive devices. You see here, for example, the number and percentages of admitted patients with one of these invasive devices. For example, here we see in this hospital, this is quite high. So 54.9% of all admitted patients had a peripheral vascular catheter. And this is, in this case, probably linked with high use of parenteral antibiotics and drugs. And this is another example of such a feedback slide from the optional healthcare associated infections module. Here you can see that in this hospital, about 1 in 4 patients, admitted patients, had an indwelling urinary catheter. So these findings can be also really important, for example, if you would like to make a link with infection prevention control. Then here you see some examples of the longitudinal feedback report. So again, we have the antimicrobial prevalence for a certain hospital, and you can see the evolution over time. And then below, you also see the evolution over time of the relative use of certain classes of antibiotics. So that is also something that is available to you. Okay, I will stop here and I will give the word back to Diane, who will talk a little bit more about antimicrobial stewardship.
Thank you. Can you keep sharing your screen, and next slide, please? Thank you. So I think that the next section here is really, what do you do after you've conducted your PPS? What are the next steps, so that surveillance is not surveillance for surveillance sake, collecting lots of data. It's really about having data for action. That's what surveillance is. So really, the importance of having effective communication of your results, both to hospital management and opportunity to give oral and written feedback to everyone involved. There's nothing worse than being involved in data collection and then not hearing back. And also the importance of timely communication, because, you know, one of the things that we found certainly is that if we collect the data and it takes us several weeks or months or even more than a week to return, what we hear the prescribers say is, well, it was not my problem, it wasn't my fault, it was another team, not my team. So if we're able to provide timely feedback, that really helps. And when you have when you collect the data, you can create awareness on antimicrobial stewardship. The bottom line for antimicrobial stewardship is about patient safety. You know, yes, we want to avoid antimicrobial resistance. That's really key. But we also want to ensure that patients are getting the best antimicrobials available for them so that they can get better. If you share back the data, you increase ownership of different groups, taking ownership of stewardship. And you can then use it to develop antimicrobial stewardship interventions. Stewardship is really a leadership approach is important, and also collaboration is really key. Okay, next slide, please, Ines. So in terms of how do you develop stewardship interventions, there's a whole range of ways that you can do this, and with thanks to Ines for and Anne for drafting to putting together some of these slides. in terms of quality improvement, so if you wanted to use a quality improvement methodology to develop your interventions, there is what we call the PDSA cycle, which is where you prepare, you plan, and then you also document. Apologies, I'm struggling to see the whole slide. Ines,
Okay.
can we change to Kieran presenting, please?
Yeah, sure. I'll stop sharing.
Apologies. And I'll start again, Kieran, if that's all. Kieran, is that okay?
Yeah, 2 seconds then. Yeah.
So there was a question here. I'll take some question. Is there any feedback about number of patients with devices having infections or antibiotic use? Anne, do you want to quickly take that whilst we wait?
Not yet. We have a dedicated person who is developing the feedback report using the statistical program R, and it's linked to our Global Pps application. And she's working hard to put in more slides from the healthcare associated infection module, and also other slides. We are continuously actually improving, trying to improve the feedback slides. It's quite some programming, so we have seen it really take some time. By the end of this month, certainly, I think another 10 slides will even be ready for the participants, and not only for the new participants, but important to know for those who are joining, who have participated before since 2015, this will be retrospectively available for you. So it works to go online and download a report, the previous reports, and you will see the slides, the new slides coming up there as well.
Okay, thank you.
Yeah.
Kieran, can you go back to the start of this session, just for the purposes of us recording? It'll be easier if I start again. So yeah, next one. Thank you. So then that way it can be edited together. So in this next session, we're going to talk about the importance of using data for action. And so there's no point in collecting data for the sake of data, but actually how do you use that surveillance data for action? The importance of effective communication of your results, both to the hospital management and the importance of giving oral and written feedback to everyone that is involved. There's nothing worse than participating in a data collection because we inconvenience the team and then we don't feed back to them. And I also highlighted the importance of timely feedback, because that's really important to avoid people saying, actually, that's not my practice, it's somebody else's practice. So if we can provide timely feedback, that is really important for changing behavior. You then use that to create awareness on stewardship, increase the ownership of different groups within the hospitals, getting involved in antimicrobial stewardship. And also, of course, you're using that data to develop antimicrobial stewardship interventions. Next slide, please. And so in terms of developing antimicrobial stewardship interventions, thank you to Ines and Anne for some of these slides. Within the WHO practical toolkit for healthcare facilities, I showed you the policy document. There is also a practical toolkit for healthcare facilities that you can have a look at. It talks about the importance of using a continuous quality improvement methodology. So often that's called the PDSA cycle, where you plan, you study, then you take action. So plan, do, it's called the PDSA, plan, do, study, and action. So that's an opportunity for you to use quality improvement to be able to develop your interventions. Next slide. So for example, it's when you want to prepare in the first part of planning, you identify who your leadership team is, and then you study your quality indicators. So this is really important. You look at the data, your feedback data from your surveillance, and then you just try and identify what your key challenges are and what your key indicators that you want to focus on are. So for example, do you want to focus on the number of antibiotic prescriptions with a documented stop or review date? Next slide. Then you need to set SMART goals within your planning. So remember, your goals should be specific, measurable, achievable, realistic, or relevant, and then timely. So an example is if you collect your data about now, June 2021, then you want to say, for example, by June 2022, 90% of antibiotic prescriptions in our hospital will have a documented stop or review date, or will have a documented indication, or for surgical prophylaxis, we are going to focus on appropriate prescribing of antimicrobials for prophylaxis. Next, please. And then again, your intervention should also be smart to allow you to reach your goals. So how are you going to be able to get to what you want to get to? Is it that you need to think about education, workshops, or having new policies in place, or have a communications plan, or have a monthly report to your hospital management? So, and now these examples are in essence using behavior change strategies, because if you have a policy in place and if you can ensure that that policy is implemented, then you're likely to see an increase or an improvement in the stop or review dates being documented. I mean, and stop and review dates being documented is not for the sake of it. If people document stop or review dates, then the antimicrobials are more likely to be stopped promptly. And we know now that we need to stop the usual everybody gets 7 days of antibiotics irrespective of what the indication is, because there is now evidence to show that shorter courses may just be as effective, and we are reducing the time that patients are exposed to antimicrobials. Next, please. And then you need to implement your interventions, which is the do. So actually, you now said you're going to put a communications plan in place, or you're going to have a policy in place, and you develop those policies or plan or education and training sessions and implement them. That's the do. Next one. In the study and adjust, so you obviously part of your prepare is also that you study because you've looked at your data to start off with. You can then perform a repeated PPS and make any adjustments. The one thing to say about quality improvement is that you need to start small. So the way a recommendation around this is that if you collect the data for your whole hospital, you may want to just choose one or two, either one specialty or one ward, to implement your stewardship intervention in, if you have the time. Because one of the reasons for that is you may think that writing a policy is going to solve your problem, and it may, but actually you may find that if you implement it within, if you have a institution-wide policy, that's fine, but you may find that you need to make some adjustments to the way you promote the policy for it to have a good effect. So with quality improvement, it's really important starting small and then expanding. But obviously you have your data and then you can see what works best. Next slide. So it's important that you consider behavior change methodology. And there is even within an hour, I couldn't fully teach you on this. And this is a health psychologist spent many years learning this, but I just wanted to highlight to you very briefly if it's something that's of interest. And we often there are different behavior change strategies that you can use, but a common one that we're tending to use within stewardship at the moment is the COM-B methodology, which is where you focus on capability. So this is around knowledge. How do you ensure that your healthcare workers have the capability that they need? Motivation, so how do you ensure that they're motivated to do what you want them to do? And then opportunity. I'm going to give you an example. So you want to improve hand washing within your institution. Capability, you have taught people how to use the hand washing. You've taught them the WHO methodology for hand washing. You've taught them the 5 moments of hand hygiene. You've done all that. They're capable. You've assessed them. They're very capable. They're motivated as well because they want to ensure that their patients are safe, but then they don't have a sink and water to wash their hands. You can see that no matter how capable or how motivated they are, If they don't have the opportunity to actually wash their hands, in the sense that there is no water or there is no sink, then you cannot change their behavior. So this is just one example of how you can consider these different aspects when you want. Again, thinking about prescribing, documentation of indication or stop or review dates. You've taught the prescribers the importance of documenting indication, because if you document the indication, when another healthcare professional comes along, they will understand why you prescribed the antibiotic in the first place. And if they need to make a change or stop, it's easier for them to do that. You've taught them that they're capable, they know what to do, they're prescribers, they're motivated because they want to stop unnecessary use of antibiotics. But then their drug chart is not available, or they don't have the opportunity to be able to write a stop or review date, or to make it easy for the nurses to see the stop or review date. So an example of an intervention that was put in place in the UK, and I know in Zambia as well, is that they now have specific sections of the drug chart for antimicrobials where there's a prompt for you to write the stop or review date and for you to write the indication, as a way to make this a little bit easier for prescribers. So these are just some examples of how you can use behavior change strategies within antimicrobial stewardship. As I said, there's a whole range of information. There is a MOOC, so a massive online learning on this, which is free and available through BSAC, that you can access, and that really focuses on behavior change strategies within the context of antimicrobial stewardship. Next slide, please. So I'm just going to give you some examples. So this is an example from our colleagues in Ghana, and this is confidential. So I'm just going to go very quickly, but it's an example of using quality improvement methodology. And this was led by Fran Kerr and her colleagues in one of the hospitals in Ghana, and has been submitted for peer review. And you can see how you use quality improvement methodology, and you can have a run chart that basically shows you different interventions that they put in place over time. So for example, they had an app on the phone was one of the interventions. Then they had an assessment of what the barriers are to changes. They implemented new local treatment guidelines. They also had a policy on the wall. So they basically started small, tried different interventions to see what worked best. And you can see there that when they provided prescriber feedback, there was a massive jump in compliance. But over time, there were periods of times when they had drops, and then COVID also was a challenge as well. Next slide, please. And again, this is published from 2 Ghanaian hospitals, which is the point prevalence survey. It's published in Antibiotics Journal, I think. And again, for this, they focused on looking at indications, missing guidelines or guidelines compliance, and then stop or review dates in notes. An example of how they use their GPPS data and presented that widely, and also how they developed an action plan for their hospitals. Next slide, please. So just to conclude then, the benefits of conducting surveillance through a point prevalence, you can do it through Global Pps, you can do it through WHO Pps. And in fact, I'll give you an example. In some hospitals that I'm aware of, they don't use the full Global Pps all the time. They do an initial one, and then they take aspects of it and use that. And then it does mean that you have to analyze your own data. But then, they focus on indication and review data, for example, and then just collect the data on those two and analyze it themselves as a way to look at how they're improving quality for quality improvement purposes. And then a year later, they go back and complete the whole Global PPS so that they can see how the hospital has improved. Because what you don't want to do is collect your data, put your interventions in place, and you're not monitoring it over time. And then in a year's time, you look at the data again and nothing's changed. So PPS can help you design stewardship interventions to promote prudent antimicrobial use and improve patient health. It can help you to identify targets to improve antimicrobial prescribing and to prevent healthcare-associated infections. It helps you to assess the effectiveness of your interventions through repeated PPS, and also to raise awareness of appropriate antimicrobial prescribing over time. Next slide, please. Okay, Ines, I think this is back to you again, and then I'll come back on again.
Yes, thank you, Diane. Okay, so now you've seen some examples of what the output of a point prevalence survey looks like. And we've talked about how you can use it to inform your stewardship interventions and activities. So for this last part of today's workshop, we have an exercise for you. And so for this exercise, you are the stewardship expert in your hospital. You are the PPS lead in your hospital, a member of the stewardship committee. And so you've done, in this case, Global Pps in your hospital. You've entered all the data. You have gone and downloaded the report. And so now you need to look at your results, interpret them, and think about if you want to improve something, what you would like to improve, and how you would like to go about this. So what will happen is that we've selected a few slides or pages from an example feedback report for you from a hospital in a country in Africa. And I will just briefly walk you through these example results. And then afterwards, we will give you some time. You can, through a link that will be shared in the chat, I think, you can go and take a look at the slides at your own pace. And then we will ask you to fill in some questions using Mentimeter. But I think Diane will explain the practical details later. So for now, I will just walk you through the example. And so you can already take a look at the report. Next slide, please. Yeah, next slide, please. This is the first page of your hospital's PPS report. And so I've shown this page earlier in the presentation. This is the one that reports the quality indicators. And so you see here again, it is divided by medical, surgical, and ICU. And then you have the respective quality indicators. Don't worry if it goes too fast. You will be able to take a look at the slides in more detail yourself later. But for now, let's go to the next slide, please. This is one that we haven't shown yet. This is an example of a slide that reports on the duration of surgical prophylaxis. So you see for our hospital, you see it's the bar on top. And then the other bars are the reference or the benchmarking data rather. And you see in red, this is the percentage of antibiotic prescriptions that have been prescribed for more than 1 day. In orange, you see the percentage of prescriptions that have been prescribed for multiple doses, but within 1 day, so less than 1 day. And then in green, you see the percentage of surgical antibiotic prophylaxis prescriptions that were administered as a single dose. Okay, we go to the next slide. Here you see an example of the AWARE classification for our hospital. And in this case, again, it's for surgical prophylaxis. So here it focuses on antibiotic prescriptions for surgical prophylaxis at the time of the PPS. And you see in green the percentage of access antibiotics for surgical prophylaxis, and in yellow the percentage of watch antibiotics for surgical prophylaxis. Again, the hospital data is at the top and the benchmarking data is are the bars below. Okay, next slide, please. This is then again for surgical prophylaxis, but a little bit more detailed, the most frequently used antibiotics for surgical prophylaxis in our hospital. And so what you mainly want to look at here is the green bars, because there's a lot of colors here, but the green bars represent the most commonly used antibiotics for surgical prophylaxis in our hospital. So we have metronidazole, parenteral, ceftriaxone, and levofloxacin, which are the three most commonly used antibiotics for surgical prophylaxis. And then the other colors are the benchmarking data. So for country, continent, hospital type, and Europe. Okay, next slide, please. Okay, I think I will stop here and give the word back to Diane so she can talk you through the questions.
Thank you very much, Ines. So, for the all on the call, thank you very much. This session is really an opportunity for us to put into practice what we would want to ensure patient safety. So it does not matter if you are a hospital clinician or a microbiologist or a lab colleague, a nurse, doesn't matter if you work in the ministry, doesn't matter if you're an administrator, everyone can get involved here. So there are some questions for you to consider, and there is a Mentimeter. Kieran, if I could just please ask, or probably Kieran, if I could ask for the direct link to the Mentimeter to be added to the chat, or you can show the slide quickly and then we can come back to that. So on the Mentimeter, it's an opportunity, it's individual work, but we are going to go into breakout rooms. So I need to explain this in a range of ways. So what will happen now is we'll go into breakout rooms. There'll be 4 of them. So there'll be about 50 people, no, about 30 or 40 per group. And then either myself, Ines, Anne, or Peter will go into one of those rooms. It is an opportunity for you to ask us questions. We thought it might be easier for you to ask questions with a group of 50 rather than a group of 150 people. So we'll go into a breakout room now. And what we want you to do is looking at the feedback data. There is a link again in the chat, and we'll post it into your breakout room shortly, which has the PDF of the data. So that's the feedback data. It's got the examples of the data that we just presented. And what we would like you to do is choose any of these random questions, any of these questions. You don't have to do them in order. You can decide to focus on behaviors. You can decide to focus on interventions. You can decide to focus on documentation. You can decide to focus on targets. But what we want you to do is basically assume that you are the lead for antimicrobial stewardship in your institution, and the feedback data that has come back to you is what is we have presented. And we want you to come up with some interventions and put it onto the Mentimeter. I really encourage you to have a go. There is no right or wrong answer, just have a go. And then when we finish, we will feedback and share back some answers so that all of us are on the same page and I've learned this. So there's an opportunity for some interactive session. So Kieran, if you can put us into the breakout rooms now, that would be helpful.
How many rooms, Dan, do we want to?
4 still is fine.
4, sure.
So if Ines and Teth colleagues and Peter and Anne, if we stay, don't accept the breakout room yet, but everybody else can go into breakout room. Thank you.
We received the invite as well. Should we join?
No, don't join yet, Peter. Just say not now. Kieran, thank you for broadcasting that message into the rooms. If you can please also broadcast the link to the PDF document, which is a Google document, that would be helpful. Thank you.
Sure.
So I think everyone's gone into rooms now, is that right?
Not everyone, no. We've still got 60 or so who've yet to go in.
So if you can please accept the invite to join a room, that would be helpful. Peter and Anne and so can I suggest that Peter, you're going to room 1, so you should be able to click on room 1 and join that. Can you see that? Thank you. Ines, room 2.
Yes, sorry, where can I see it? Sorry.
It came up as a pop-up for me.
Oh, I closed the pop-up, sorry.
Okay, so maybe wait a moment then. Wait a moment.
Yeah, sorry.
And did
Ines?
you receive, sorry, Peter, did you
Yes.
receive the link for the PDF?
Ines, you should go to more at the bottom and go to join breakout room.
Okay, I see it.
So yeah, if you're going to room 2, please, Peter, room 1,
Yeah.
and room 3, and I'll go into room 4.
I'm going to room 1. See you later.
Yes, please. So we still got about 50 people who haven't joined.
Yeah, 52.
I'm wondering if we need one more. I'm wondering if we should keep this as a room as well, but we haven't got enough. So is that because people haven't accepted to join, or do you know why?
Yeah, that's the reason. Yeah.
Okay. Is it possible to what do we do? Is there another option, or we just need to?
It would reset all of the rooms again, Diane, if I
Okay,
was to
no,
force
we're
them.
not doing that. Don't worry. Okay, we've got 47 people in here, so. Yeah, but Will, are you okay to go into room 4 then?
I won't be able to answer any questions. That's the thing. So I can just stay in here and tell people to go into their relevant room if you go
Okay.
into room 4.
Okay, I'll go into room 4 then. That's fine. Thank you. Okay, so join. Thank you, Kieran. Thank you, everyone. We've still got some people in breakout rooms, I assume.
Yeah, they're just coming back out. Dan, do you want me to share the results?
Yes, please,
for
the
the Mentee?
Mentimeter. That's perfect. Thank you so much. Excellent. This looks great. Excellent. Okay. Right. So, is everyone back in now? We've got 134 people back in. Is that all the breakout rooms now closed, Kieran?
Room 1 is closed.
Yeah. Okay. Okay. So, this looks great. Okay. So there are two things. Will has just put something into the chat, which is about evaluation of today's session. This is different from the post-training survey, which leads to the slides and a certificate. This is really for us to understand how you found the session. So it's about how you thought you thought the session was delivered, and if there's anything we could do better for next time. We've got one more training session that we're going to do on gender and inclusion. So we'll learn from this for future events. So please do feel free to complete that evaluation form. Okay, so back to this. This is really great to see. So looking at the feedback data, what the word cloud does is the phrase that people use the most becomes the biggest. And what most of you have chosen, which was also our choice, is surgical prophylaxis. But I also like that people chose stop or review date, stop date. So again, looking at the quality indicators, you could see where you wanted to focus. I can see that some people have said they want to focus on carbapenems, duration of treatment, antibiotic prophylaxis. This is also linked to surgical. So there's a lot of surgery also dotted elsewhere. But I think that this is really important. WHO reserve group, that's a really important one, because in the surgical prophylaxis compared to other countries, there was a big use of reserve antibiotics. Next one, please, Kieran. So how do you define targets, or what would you do for your targets? So people have got a range there, you want to improve prescribing pattern. I think so one thing to highlight here is that your target needs to be quite specific. So I really like the example here around in June 2021, more than 50% prophylaxis of antibiotics for obstetrics. So I'm assuming the person has then said by X date, we want to do one. I like the one in the middle there that talks about to increase stop or review date documentation to at least 70% by the end of, I'm assuming that's 2021, not 2020. And then people want to shorten duration. That's really important. And again, you want to, someone said shorten antibiotic use post-surgery by 1 to 3 days. Can you scroll down on this one, Kieran? Are there any more? Or was that it?
I think that's...
How many people completed this one? 51 people completed it. It's fine. It's okay. It's supposed to scroll. Yeah, there we go. So by X time and X% patients receiving surgical prophylaxis will do so for less than 1 day. That's a really good example of a target for surgery. Next one, please. So what would be your target audience? So some have said nurses, doctors, surgeons. So depending on what you chose will depend on who your target audience is. So obviously if it's surgical prophylaxis, you may choose to focus on both the surgeons and the nurses, and your focus for them will be different. So for the surgeons, you'll be wanting them to prescribe to make sure that they prescribe the surgical prophylaxis in the first instance. For the nurses, it will be that they give the surgical prophylaxis on time. And also the nurses could prompt the surgeons to review the antibiotic, the length duration of antibiotics as an example. And yeah, surgeons are also doctors. There's some people wanted to focus on lab staff. So again, it depends on if your focus was on diagnostics. And you can also focus on patients. Within a hospital, it's sometimes a bit more challenging, but patients can also ask the question, do I still need to be on this antibiotic? Next slide, please. Next one. And then what behavior you want to change. So there's a range here. So prescribing patterns, that's good. Behavior to prescribe. Keep scrolling down, please. There's a behavior around giving prophylaxis as a single dose or stopped within 24 hours. Yes. And then proper documentation of stop or review date. Yes. Behavior, non-compliance to guidelines is a behavior. Surgical prophylaxis use is a behavior. These are all behaviors. So there's a key one there around prescribing patterns and the belief that microbiology is not important in prescribing antibiotics. That's a really good one. And so how do we start to encourage people to make sure that they send blood cultures or to send cultures for analysis so that you can then have targeted prescribing? Adherence to guidelines as well is important. Next one, please, Kieran. Again, was behavior would you want to change? And that's fine. Next one, please. And then what stewardship interventions would you put in place? Somebody said prospective audit and feedback and training. That's really important. Guidelines, that's really important. IV to oral switch, that's really important intervention. Education and training, lots of education and training. Dose optimization, guidelines, chart reviews on a regular basis. That's a really important one. Restrictive prescriptions, yes. So you can, for the reserve antibiotics, you can do a restrictive guideline, which says if you want to prescribe these antimicrobials, you need to get permission first, as an example. And approval, that's it. Approval for extensive use. Training, again, conducting PPS routinely, formulary restriction, encouraging physicians to stick to guidelines. It's very difficult though. One thing I haven't seen there is availability of the guidelines. Can your prescribers easily access guidelines? And this is an example of why we created the CWPAMS app. So if you go onto any of your app stores, you can find, if you search for Commonwealth Pharmacists Association, you'll then be able to link to the app easily. Next one, please. So this question here is, have you previously documented your intervention? And I think that this is really important. I can see that some people have said they're unsure. What we mean by this is that when you're developing your interventions, it's really important that you write it down somewhere, either in your report or your presentation or your reports to hospital management, and that you clearly highlight what those interventions are. Who is it targeted at? What is it targeted? What are you targeting or focusing on? And when do you want the interventions to take place? It's a good way. It's a way of you having a record of the different interventions that you have put in place. So, for example, if your hospital management or the medical director comes and says, why do we keep having resistance patterns? You can say, well, this is the things that we have tried at different time points, and this is what worked and what didn't work. So that's why it's important to document your interventions. Next slide. I have a feeling that might be the last one. How will you measure effectiveness? Yeah, PPS, there's so many different ways. Pre and post test. So yes, if you do an education and training session, you can do a pre and post assessment of people's knowledge and understanding. Okay, next one, please. I think, is that the last one, Kieran? Okay, so if you can please then just go to our slide set again, please, Kieran. Yeah, we'll find a way to share the Mentimeter results. So again, we'll share this when we get the when we do the post-training feed questionnaire. So once people complete it, we'll send a certificate as well as a set of slides in some way. We're not sure yet how we'll do that. We'll need to put it online somewhere or a way for you to access it because they're large files. Next one, please, Kieran. Next one. Next one. Keep going. One more. Okay, so just very quickly to highlight and to provide feedback for you so that we're all on the same place. The post questionnaire will be sent to the emails that you used to register. If you have been able to access this without registering, I would recommend that you put your email into the chat box, but only if you didn't register, please. And we'll collate those emails and send you the post feedback, the post training survey. So anyways, just highlight very quickly here, you can see that from a medical point of view, guidelines were missing for 60% of the patients. Stop of review date was missing for 46%. So you may want to focus on that from a medical department point of view. And then for surgery, 98% had missing guidelines and 40% had missing stop or review date. So for, most people chose surgery, but there was some information there around missing guidelines for medical parts as well, medical prescribing. Next slide. And then for surgical prophylaxis, some of the key things here is a prolonged surgical prophylaxis. So all more than one day, 100% was more than one day. And then whereas in the country, so in the same country, it's 92% is more than one day. I mean, either way, it's still not, it's still quite a lot. And then compared to Europe, it's 24% is more than one day. So there are still activities through different countries across Europe to try and bring that down. Because once you're going past the one day, it's no longer prophylaxis, it's probably treatment. Or medical, or it's no longer prophylaxis, it's treatment. Obviously, for some surgery, you need to redose. For long surgery, you need to do 2 doses, but there should be more than one day is no longer prophylaxis. Next slide. And then in terms of the there's high use of watch antibiotics and some use of not recommended in the country, but in this particular hospital, a high use of watch antibiotics. So really important to focus on that and to consider what can you do. Again, if you look at that from the hospital to the country to Africa, and then to tertiary hospital, and then to across Europe as well. Okay, next one. Again, you can have a look there in terms of the use of antimicrobials and the particular antimicrobials that were used in that surgery. Is that according to your guidelines? Or if there's no guidelines, should you be developing guidelines in the first instance so that people can use that? One thing I can highlight is that for those in Africa CDC is developing some guidelines at the moment for countries where they don't have national prescribing guidelines already. But in many countries, there are national prescribing guidelines, so really important that people are following those and using them. Next slide. So, if you wanted to set some targets for your surgical prophylaxis, you could set it based on duration or which antibiotics were mostly prescribed or what diagnosis. I think, in a quality improvement way, you don't want to have too many targets at the same time. It's always helpful to have 1 or 2 and really have focused attention on that. And then you can move on to the next one, because otherwise people get overwhelmed and fed up. Okay, next slide. I think that may be the last one. Okay. So thank you so much. Actually, Will, back to you.
Yes, thank you very much, everyone, for attending. I think it was a really great session. As we've mentioned, we're really grateful if you can complete the SurveyMonkey link that's been shared in the chat box. That's based on how you found today's event, so that we can learn from how we've administered the event and delivered the event going forward. Just to stress, this is distinct from this is different from the post-training evaluation, which will be sent to you by email. So please keep an eye out for that. And once you've completed that, you'll then be able to access the slides, the Mentimeter results, and also a certificate of your attendance. So yes, thank you again from Thet, from CPA, from Global PPS team, from Peter, the WHO PPS author, for attending. Thank you very much, and I hope you'll consider attending future events as well. Yes, thank you very much.
Thank you all so much. And